Good afternoon and welcome to the RAISE Full Advisory Council meeting. My name is Jonathan Weston. I'm an Aging Services Program Specialist with the Administration for Community Living, and it is my pleasure to welcome Maura Kelson joining us today. Maura is the Principal Deputy Administrator, performing the duties of the ACL Administrator and Assistant Secretary for Aging. Maura, welcome. We look forward to your framing remarks this afternoon.
Thank you, Jonathan, and welcome everybody. And thank you for joining today's meeting of the RAISE Family Caregiving Advisory Council. As Jonathan said, my name is Maura Kelson, and I've been with ACL for about 18 months. Before joining ACL, I was with the HHS Office of the Assistant Secretary for Health. And I took over the role of Principal Deputy Administrator, performing the duties of the ACL Administrator and Assistant Secretary for Aging in October. I want to first start by thanking council members for this opportunity to meet with all of you as you are resuming your work to ensure that the national strategy to support family caregivers remains the North Star for how we change the way we support caregivers in this country. It's absolutely fitting that this meeting is happening in November, which all of you know is National Family Caregivers Month. The work of this council and all of our partners is critical for ensuring family caregivers are recognized and supported as invaluable parts of our long-term care system. The success of the council's work is already making a meaningful impact on family caregivers, with federal agencies completing or nearly completing many of the 350 actions outlined in the 2022 National Strategy. ACL is so proud to be the lead agency charged with supporting the work of this council, but we cannot overstate how strong support has been across the entire federal government. It's been 5 years since we began this journey, and almost 3 years since the RAISE and Grandparent Advisory Councils began working together to coordinate their impact. Over the past years, we've seen federal departments and agencies step up in amazing ways to foster collaboration and identify actions that can be taken to support the 53 million family caregivers in our country, as well as friends and neighbors who perform caregiving roles. Our message is clear to all caregivers. We are working hard to collaborate, update, and innovate within the family caregiving arena. We recognize the challenges family caregivers are facing, and together with many of our federal agencies as partners, we are making real advancements. But this effort is not just about the two councils and the federal government. It is a broad coalition of national and state organizations, community-based organizations, advocates from across the caregiving spectrum, as well as state and local government agencies. We at ACL are so grateful for this collaboration, and we will continue to cultivate partnerships wherever and whenever we can. By working together across all sectors of society and across administrations, we can create a path that improves the lives of America's family and paid caregivers. So thank you for gathering today to see where we are at this moment of time, and for looking ahead towards updating the strategies in ways that will, among other things, strengthen connections between family caregivers and the paid caring workforce. I do want to take one moment to review some of what the federal agencies who committed to actions in the strategy have accomplished to this point. We've seen the allocation of $20 million in new funding for technical assistance to support implementation of the strategy through ACL's new caregiver projects of national significance. ACL also awarded $2 million in new funding for state implementation grants to demonstrate approaches for implementing the strategy. That funding went to 4 states: California, Maryland, Massachusetts, and Wisconsin. HRSA is delivering new family caregiving training via its 2,700 partnerships with academic, primary care, and community-based organizations. CMS's 2024 physician fee schedule final rule included new Medicare payments for family caregiver training. SAMHSA and FEMA are developing a curriculum to provide peer support for caregivers during emergencies. AmeriCorps Seniors volunteers are beginning to provide respite services for caregivers. A new VA program provides financial and legal support for family caregivers through the Program of Comprehensive Assistance for Caregivers. CDC is engaged in new family caregiver data collection efforts. NIA is funding $5.4 million in new research related to the experiences of family caregivers for people with Alzheimer's disease and related dementias. In addition to all this outstanding work being done at the federal level, I want to recognize the Act on Raise campaign, which brings together a host of national organizations, many of whom are on this Zoom today, to support the efforts of the two councils and the national strategy that the councils produced. Today, the council will be discussing one of the most important issues affecting caregiving, the intersection of family caregivers and the professional direct care workforce. Direct care professionals, as we all know, are often the key to enabling people with disabilities and older adults live as an independent life in the community rather than in an institution. And they are also an indispensable part of the system of supports that family caregivers need as they navigate supporting their loved ones and taking care of themselves and their other responsibilities. Year after year, we speak about the more than 50% turnover rate in the direct care workforce and about providers declining referrals and closing programs due to lack of staff. And we point to the future demand for direct care professionals with more than 1 million new staff needed by 2030 as the number of older adults and people with disability grows. We see community providers who are unable to offer supports to qualified families because they have a shortage of personnel. These issues need to be addressed. And that is why ACL is so proud of the fact that as part of the effort to address these issues, we established the Direct Care Workforce Strategy Center. Working with many partners, the center is charged with being a change agent, driving systems change in several key areas. And those are wages and benefits, training, mentoring and supervision, helping foster state partnerships that can use all the levers available to them that include aging and disability, Medicaid, and workforce agencies, and increasing respect, recognition, and growth opportunities for the direct care workforce. Thank you to the Department of Labor and our fellow HHS agencies, including CMS and ASPE, for being our partners in supporting the Strategy Center. The focus of today's meeting marks a new chapter in our efforts to support family and paid caregiving. But it's not a new idea. It was included in the 2022 strategy. Still, we really think that this meeting is an opportunity to begin a new, intense effort to forge a coalition that will be much more than the sum of its parts. I've seen throughout my career that when an issue becomes a focal point, positive change results, not in weeks or months, but over time and with sustained effort. So I'm going to close by thanking everyone participating today for committing to such a sustained effort. And thank you also to the amazing speakers who are going to help us today outline a vision for the future. Council members, thank you again for providing me with this opportunity to speak. And please know how much I'm looking forward to supporting your work. Now I would like to welcome Melissa Saz to conduct a roll call of our council members before I return to open the floor to council members for a few comments. Melissa, over to you.
Thank you, Maura. So to begin the roll call, we will first call on you, Maura Carlson, to make sure that you are on for official roll call.
I am here.
Perfect. We will move on to co-chairs, Jonathan Cotter.
I'm here.
Okay. Carol Zenio.
Present.
Moving on to non-federal council members, Jesse Orsico. Okay. Next is Neil Henderson. Sharon McDaniel. Daniel Murphy. Denise Myler.
I'm here.
Nancy Ritchie.
I'm here.
Gloria Sanchez.
I'm here.
Kezia Scales.
Present.
Deborah Stonewalls.
Hi, everyone. I'm here.
Felicia Walker Hayes.
Present.
Jennifer Wolf.
Present.
Moving on to the federal council members, Liliana Charabadaki from the Administration for Children and Families. Joanne Newsome from AmeriCorps.
I'm here.
Helen Lamont from the Assistant Secretary for Planning and Evaluation. Lynn Gall from the Bureau of Aging and Disability Resources, Wisconsin Department of Health.
Present.
Greta Kilmer from the Center of Disease Control and Prevention. Jody Sumaraki from the Centers for Medicare and Medicaid Services.
Present.
And Melissa Harris from Center for Medicaid and Medicaid Services.
I'm here representing CMS.
Lisa Schifferell from Consumer Financial Protection Bureau. Courtney Simmons from the Department of Agriculture.
Present.
Rebecca Davis from Department of Education.
I'm here.
Sarah Glenn from Department of Labor. Catherine Capana from Food and Drug Administration. Diane Mitchell from the Food and Drug Administration. Joan Wise from Health Resources and Services Administration.
Good afternoon. I'm here.
Jolie Crowder from Indian Health Services. Michelle Archuleta from Indian Health Services. Amelia Carracker from National Institutes of Health.
Amelia Carricker, present.
Thank you. Jennifer Bishop from the Office of Assistant Secretary of Health.
Present.
Carol Cecil from Substance Abuse and Mental Health Services Administration.
Here.
And lastly, Jill Dubbard from the Veterans Affairs.
Good afternoon, present.
Thank you. That concludes roll call portion. I'll turn it back over to Maura.
Thank you, Melissa. I'd like to open the floor to council members and ask for your impressions of the progress on the national strategy implementation so far. And please don't be shy if you have thoughts.
This is Gloria Sanchez. Can you hear me?
Yes, thank you.
I'm over here in California, with a small city of Menifee with about maybe 11,000 residents. And I've taken away from this and shared with them the many inroads that we've made and shared with them what is going on and what we hope to accomplish in the years to come. And they are all very grateful for all of the input from the different federal agencies as well as local. And in working with the state of California and their master plan on aging, they are looking at this strategy so they can take with them information and implement it and work with them together so we can have that in itself. But also, we also have the Inland Empire, which is also doing their own master plan on aging. So what this tells me is that the entire nation is now looking at implementing some form of master plan on aging to serve all our seniors. So it starts with the federal government, and I'm really pleased to let you know that people are embracing everything that this council is doing. Thank you.
Thank you very much. And I think we will have more of that a little later in the session related to some of the related work that the federal government is doing more generally on a national strategy on aging. And anybody else interested in sharing thoughts?
This is Carol Zernial. I just wanted to to thank and congratulate the various federal agencies for the work that they have done. It's an impressive amount of accomplishments when you read the reports. I think all of our communities are looking for the
Oh, you are going
Right.
in and out a little bit. I don't know if
Recommended-
others are having problems.
strategy. Uh, sorry. Yeah. Thank you.
Sorry,
Focus.
oh, we're having some challenges. I think we'll go to the next person. Jennifer Wolf, would you like to share?
Sure. I'll start where I think Carol ended in terms of what we could hear, in terms of expressing just tremendous gratitude and for all of the work of bringing together the national strategy and the various federal and non-federal constituents who are here and who are working on the national strategy. I was part of the 2016 NASM committee that produced the report Families Caring for an Aging America that recommended a national strategy. And it's just incredible to see all of the progress that has been made over the last 8 years. That both bringing together a strategy and then seeing, importantly, the momentum towards recommendations and implementation, leading to real change in terms of being able to reimburse clinicians to educate caregiving. It's just incredibly exciting, and to see the progress and to see how multifaceted it is across multiple sectors and dimensions. So I'll stop there.
Thank you. Deborah?
Thank you, Mara. I echo those sentiments, Jennifer and Carol, what I could hear from your statements. I think this has been, frankly, one of the most exciting initiatives in my professional life, to simply observe the process from an idea to an act to then the councils, both the RAISE Council as well as the Grandparents Raising Grandchildren Council, to see them come to fruition. What has been most impressive to me is the commitment across the board from all of the federal partners, from all of the nonprofit partners, from the foundation partners to the states, the local communities, most of all from caregivers themselves. Just the sustained commitment to joining together and making a difference. I think that collective, this has not been an initiative that started with a lot of steam and then fizzled. If anything, it has been an initiative that has continued to grow and expand and just, I think, ignite passion across the country. So I applaud ACL's work in not only holding it together, but in casting the net far and wide, and then providing that framework for all levels to pull together and make a difference. So it's been very impressive.
Thank you, Deborah. And would anybody else like to share? I don't see any other hands up right now. Well, some of our comments did really talk about momentum and initiative and how we're going to continue to grow. So as a follow-up, I'd like to ask the council members about any ideas for key areas where the strategy needs to go with respect to new actions or outcomes. And I think we started to hear a little bit of that in the reflections on the strategy. hearing none, just before I turn the meeting back over to.
Lynn has her hand up.
Oh, I'm sorry. I can't see all the hands. Please go ahead.
Oh, that's okay.
Oh,
Thank you.
Great.
I just wanted to say this isn't really taking the strategy so much in a different direction. As I also have to give a plug for funding because Wisconsin, our state, we were one of the 4 states that got the newest implementing the national strategy at the state level grants. And I just have to say what a wonderful catalyst that has been to get people involved and an opportunity to do things that we weren't able to do before. And so if there would be one thing that I would hope I think everybody would benefit from is making more of those sorts of supports and grants available to get the word out and to start to work on some of these things in ways that we haven't been able to before. So that's not necessarily changing the strategy so much, but just I think a really important part to implementing the strategy is we've done a lot without putting money toward it, and just using what resources we have. But I just have to say it really got people excited in Wisconsin about coming around together to work on these things together, objectives that we're going to work on together. And it really was a catalyst. So just wanted to share that.
Thank you. Really helpful. Jonathan, would you like to go next?
Sure. I just want to also just appreciate that I think as we're having our discussions and talking about action items, we're really thinking about the entire lifespan. My groups and the groups that I spend much time with are really around medically fragile children. And so we're obviously talking a lot about the elder care and aging population, but we're also talking about kids and in the community with caregiving, in the community with medically fragile children. And I really appreciate how we're approaching it across the entire lifespan.
And that is absolutely the approach that ACL takes with both older adults and people with disabilities who we provide funding for services for. So thank you for that. Jennifer Wolf?
Yeah, again, I think that my comment fits within the strategy, but is really motivated by the importance of identifying family caregivers at the point of care when they are potentially most able to benefit from services. And that I think the work that we've been doing is so important in terms of the recommendations, but we really need, I think, carrots and sticks so that we move beyond sort of talking about person and family-centered care as a concept to making it a reality, which means that it's not person and family, that there are actual measures of what it means to engage family and policies that are geared towards making that happen. And so I think there's a range of ways we can do that. But I think sort of really thinking through the implementation. And I would say that this is an area where I think there's a lot of opportunity for small pilot funding to work with providers and organizations to figure out what works and to scale it. And I think that this goes beyond sort of, I think it's the importance of NIH investigator-initiated projects. It can't be overstated, but those are long I think that we need smaller rapid cycle projects to really figure out how to do this because there's sort of a major gap in evidence in this place. Thank you.
Thank you. And I believe Kezia, I apologize if I got your name wrong.
No, that's perfect, Kezia. Thank you so much. I'm really energized by the conversation that we will be having throughout this afternoon around updating the strategy to strengthen the direct care workforce component. So I just wanted to flag that, and I know we'll have opportunity to talk much more about that. But I also just wanted to offer, I think this is baked into the process. So maybe doesn't even require saying out loud, but just making sure that as we revisit and revise the strategy, we're really explicitly building on the progress that has already been made and really well documented so that we're pushing ourselves in the process to think about, not sort of moving beyond the actions as they are currently articulated to, what might come next, what might be the next step in some of those actions. So it's not necessarily a departure from what's already been prioritized, but just making sure that the way that we're articulating it is as sort of progressive and forward-looking as it can be.
Thank you very much. I don't, and with apologies if your hand is up and I do not see you, Jonathan, I'm going to turn this back over to you. I really want to thank everybody for their initial thoughts. I think absolutely the entire conversation is just going to flow perfectly from the reflections that folks have shared, and I'm going to turn it back over to Jonathan. Thank you all.
Maura, thank you, and thank you very much for your leadership here at ACL, particularly as we look forward towards reframing the national strategy and updating it in the months and year or so ahead of us. What I'd like to do now is to introduce our fearless leaders, our council co-chairs for RAISE. First off, let me introduce Jonathan Cotter. Jonathan is a public health and advocacy expert focusing on medically fragile children and their families. And he is currently serving as the Chief Executive Officer and also the founder of the National Center for Pediatric Palliative Care Homes. I also want to take a moment and introduce Carol Zernial. Carol holds a master's degree in social gerontology and has been in the field of aging for over a quarter of a century. Currently, Carol serves as Executive Director of the WellMed Charitable Foundation and is Senior Vice President of Social Responsibility for WellMed Medical Management. On a personal note, I'll say that I'm now at my 7th month here at ACL, and both Carol and Jonathan have been simply incredible at showing me their thoughts on RAISE and their thoughts on direction moving forward. So Jonathan Cotter, if we can turn to you to kick off the Act on RAISE campaign's vision for the updated strategy and introduce our panel and our aims of this session. Thank you, Jonathan.
Sure, that sounds great. Thank you very much, Jonathan, for that kind introduction. I would like to welcome you all to the first panel, the Act on RAISE campaign's vision for an updated strategy. As the Council begins to deliberate pathways and direction for the national strategy to support family caregivers, we felt it would be instructive to hear from several of the federal policy and advocacy leaders focused on RAISE and family caregiving overall. Today, we are pleased to welcome the Act on RAISE campaign, which is chaired by Jason Resendez, President and CEO of the National Alliance for Caregiving. Jason will be joined by several other panelists, including Tori Cross from Caring Across Generations, Natalie Keene, Justice and Aging, Sandy Markwood from US Aging, and Rhonda Richards from the AARP. The Act on RAISE campaign is focused on the implementation of the actions outlined in the national strategy to support family caregivers. The campaign brings together stakeholders across the caregiving continuum. This includes aging and disability groups, as well as patient advocacy and caregiving organizations. The campaign is focused on mobilizing and aligning stakeholders, educating policymakers, and raising awareness of the impacts of caregiving on families, communities, and the economy. It is a pleasure to welcome them to the RAISE Council to present on their thoughts for an updated strategy. Jason, welcome. The floor is yours.
Great. Thank you so much, Jonathan, for that kind introduction. And also to the Council for including the Act on RAISE campaign and the National Alliance for Caregiving in today's critical meeting. And I also I would be remiss if I didn't start with Happy National Family Caregivers Month. What an opportunity to not just celebrate, but to honor the contributions of family caregivers through our collective action and collaboration. I'm just making sure. Great, slides are up. I want to begin by asking you to imagine Sarah, a working mother who spends her evenings caring for her aging father with Alzheimer's. or Michael, who had to reduce his work hours to help his wife through cancer treatment. These are all the faces of America's 53 million family caregivers who provide ongoing complex care, folks in the National Alliance for Caregiving's network. They're invisible donors to our healthcare system and economy who provide an estimated $600 billion worth of unpaid care annually. That's more than all federal and state Medicaid spending combined. Today, I want to talk about how we can better support this growing community through coordinated action across government, leveraging the National Strategy Framework. This vision is rooted in the collaborative efforts of the Act on RAISE campaign, which is supported by the John A. Hartford Foundation and led by NAC, and it brings together, as Jonathan mentioned, more than 120 organizations across aging, disability, and patient advocacy, the care continuum. Together, we're working across the care continuum to drive action on and to strengthen the national strategy to support family caregivers. And here you see an overview of our steering committee, which I think represents leading voices at the national level in support of care across the lifespan. Next slide. Since the launch of the national strategy, we have worked across the care ecosystem to raise awareness of the strategy and its actions nationally, focused on the media, congressional offices, the administration, the private sector, and philanthropy. We've worked through stakeholder mapping and engagement across different stakeholders to assess barriers to implementation and opportunities to strengthen the process moving forward. And we've identified priority areas for continued mobilization as a coalition that we believe can help advance the vision outlined in the strategy. This work has culminated in a set of key recommendations for strengthening the national strategy framework and for ensuring it continues to evolve into a best-in-class strategy that delivers change for family caregivers. And I'm going to share these recommendations before turning the mic over to my colleagues from the coalition to provide a deeper view into recommendations in support of specific strategies and goals and outcomes within the strategy. Next slide. First, we want to start with our recommendations for Congress, and I think this picks up nicely from some of the conversation from council members. We see Congress has the power to create transformative change by making critical investments. Right now, our National Family Caregiver Support Program operates on just $207 million, a fraction of what's needed to support millions of caregivers providing care for older adults. We're calling up for Congress to nearly double this investment to $410 million. We also call on Congress to increase funding to implement the national strategy at the state and national levels through the projects of national significance, which would cut across the care continuum in terms of providing support. Think about what this means. This means more respite care for exhausted caregivers, enhanced training programs, expanded support services, enhanced implementation capacity across states. But we know that funding isn't enough. It's necessary, but not sufficient. We also need to reauthorize the RAISE Family Caregivers Act with the Older Americans Act. This reauthorization isn't just about maintaining the status quo. It's about ensuring we can continue to evolve and improve our national strategy to meet the challenging and changing needs of family caregivers. And we're working to advance these congressional requests through our advocacy work across the coalition, including in an upcoming Hill Day taking place next week. Next slide. And this brings us to our second pillar, the RAISE Council's leadership. All of you, you are the architects of our national caregiving strategy. You see the big picture, but you also see the work still ahead, as evidenced by many of your comments at the first part of today's meeting. To advance your work, we're calling on the council to develop a comprehensive congressional action plan. Think of it as a blueprint for change. We're asking for specific policy recommendations, clear funding requests, and explicit identification of where new authorities are needed to continue to expand on the ideas outlined in the national strategy. And importantly, we recommend developing timelines and metrics that answer the question, how do we know if we're making a difference? We need to track not just what we're doing, but what it's actually leading to and improving in terms of the lives of family caregivers. We are excited about the amazing actions and continued progress outlined in the recent report to Congress, and think as the strategy continues to evolve, there's opportunity to capture proof points in terms of impact, whether through stories or through more quantitative approaches, so that we can communicate the impact and power of the national strategy as we continue to advocate. We also see opportunities to learn from other strategies. The national strategy to combat anti-Semitism is a great example of robust and detailed congressional requests and funding requests that could serve as a model for the national strategy to support family caregivers. Next slide. Finally, we want to talk about federal agencies, the engine room where policy becomes reality. We've already seen what's possible when agencies think creatively. Take CMS's recent addition of caregiver training service codes to the physician fee schedule. This seemingly technical change means healthcare providers can now be reimbursed for training family caregivers, a potential game changer for families struggling to manage complex medical care at home. We want to see more innovations like this. We recommend agencies to boldly use their existing authorities to support caregivers. Find and maximize every possible funding stream to support state and national initiatives. Build robust data systems that tell us who we are reaching and who are missing and what's working. We think this last point is crucial. Without good data, we're flying blind. We need to know if caregivers in rural areas are accessing services at the same rate as urban caregivers. We need to understand if younger caregivers have different needs than older caregivers, and we need to identify where programs are succeeding and where they're falling short. And now I want to take this a little bit deeper into specific actions, goals, and outcomes that the Act on RAISE campaign has prioritized through our national engagement and stakeholder mapping. Next slide. My colleagues will provide recommendations for continuing to advance the goals and outcomes outlined here. Goal 2, Goal 3, Goal 4. And to start that process, I want to turn it over to my colleague, Rhonda Richards from AARP.
Thank you very much. I'm going to be talking about Medicare, and good afternoon to the members of the RAISE Family Caregiving Advisory Council and ACL. Appreciate the opportunity to be part of this important Act on RAISE presentation today and celebrate National Family Caregivers Month as we look at ways to improve and build on and update the national strategy, and actions that can be taken and should be taken to better recognize, assist, include, support, and engage our nation's family caregivers. Right now, I'm going to focus specifically on Goal 2 here in terms of advancing partnerships and engagement, specifically that family caregivers are recognized as essential partners in the care team of the person that they are supporting, and important steps that in particular that Medicare can take to do this. There are over 59 million people age 65 and older last year who relied on Medicare for their health care. But it's also important to remember that Medicare provided health care to about 7.6 million people with disabilities under age 65 last year. So Medicare is providing care to 66 million people, and actions in Medicare can drive actions by other payers. So what Medicare does matters, not just for the people that are receiving care in Medicare now and their family caregivers, but also for its potential impact to drive change beyond, for people more broadly and their caregivers beyond Medicare. Given that many Medicare beneficiaries may have a family member or friend helping them with things like eating, bathing, and dressing, and managing appointments, coordinating care across providers, navigating Medicare, managing finances, paying for care and transportation and rides, Medicare has a responsibility, and it's also in Medicare's interest to recognize and support family caregivers for the beneficiaries, for their health and well-being and outcomes, and Medicare overall and their family caregivers. Family caregivers can mean the difference between someone getting out of bed, eating, taking their medications, getting to the doctor or other providers, following a treatment plan, having a good quality of life and connecting with other people, the social connections that prevent isolation and loneliness, versus unnecessary hospital or emergency room visits, unnecessary nursing home stays, preventable falls, or other adverse health consequences, things that are bad for people on Medicare, their family caregivers, and Medicare and taxpayer dollars. Family caregivers who are supported can better help the person that they're caring for with Medicare and improve their own health and well-being when they themselves will use Medicare in the future, if they're not already. That's why it's essential for Medicare to better recognize and support family caregivers as critical team members, and why it's such a big deal that Medicare this year, for the first time, is paying healthcare professionals, as Jason referenced a minute ago, solely for the time spent training family caregivers in person in things like behavior management and modification, and how to help their loved one with daily activities like the eating, bathing, and dressing, transferring, like if you're getting up out of a chair or bed, and how to do that safely, mobility, communication, etc. Training in all these areas is critical. But it's also important for Medicare to implement payment reforms and other policies to better support and train family caregivers providing complex care. Caregivers may often perform medical and nursing tasks after discharge from care in a hospital, other facility setting, home health, or on an ongoing basis providing these kinds of tasks. Nearly 6 in 10 caregivers assist with medical nursing tasks. Things like injections, tube feedings, wound care, operating specialized equipment, and more. African American and Hispanic caregivers more often help with medical nursing tasks than do white caregivers. And caregivers of spouses and partners more often assist with these tasks than all other family caregivers. But too often, family caregivers aren't getting the training and support that they need. That's why CMS and Medicare should enhance the implementation and adoption of caregiver training services through the Medicare physician fee schedule. Things like expanding caregiver training services to cover medical and nursing task training, and providing technical assistance to establish learning communities to support implementation of caregiver training services across healthcare systems and providers. Act on Raise and many advocates were very pleased that Medicare has taken some important steps on this. In fact, starting next year, January 1st, 2025, Medicare will pay for caregiver training services in direct care services and supports. These are things that support care for people with ongoing conditions or illnesses, or to reduce complications. Things like helping prevent ulcers, wound care, infection control, things like potentially medication management that will help train family caregivers in medical nursing tasks that they're performing. Behavioral and management and modification training will also be available individually to caregivers. And it'll be important to see how all of this is implemented. Do providers and health systems know about these billing codes and the training that they can now be paid to provide? And are they actually providing it? Do caregivers know about it, and are they able to ask for it when they need it? Is the training covering all the kinds of things that caregivers do and that they need and that could be covered? Are any changes needed?
Could you slow down, please?
Sure. And how it's working. It's also important to note that these caregiver training services will be available via telehealth in 2025, which will increase caregiver access to the training. It's important for CMS to provide technical assistance and have learning communities to support the implementation of these caregiver training services provisions. To look at best practices, things that work well, things that don't work well. And it's important to get the word out about those things and those learnings to maximize the efficiency and the effectiveness for everybody involved, because that also is then an incentive for healthcare professionals to offer the training. And making sure that people know, again, the experiences, the tips, the successes, the learnings. So there's an opportunity for CMS to work with providers and advocates and the private sector to help ensure that these provisions are implemented smoothly, that they improve care for beneficiaries, and that they make it easier for the family caregivers to provide the care and give them the confidence to do so. Also helping potentially save Medicare money. Another critical step that CMS has taken and has launched this past July is the implementation of the Guiding and Improved Dementia Experience Model to improve the care and quality of life for Medicare beneficiaries with dementia, reduce the strain on their family caregivers, and help people live in their homes and communities. It will achieve this goal through Medicare payments for a comprehensive package of care coordination and care management with caregiver education and support and respite. One of the things that's very important about this model is that from the very beginning, in day one, it recognizes and supports the role that caregivers play in caring for their loved one with dementia, because that doesn't always happen in the day-to-day provision of care. That's the experience of many family caregivers, unfortunately. This model will be tested for 8 years. And like I said, caregivers will be able to access things like education, training, support services, a 24/7 helpline, a care navigator, and importantly, respite care to give caregivers a temporary break in their caregiving responsibilities, and connections with community-based providers. These are the essential kinds of supports that people caring for someone with dementia need, and truly that a lot of caregivers could use and benefit from as well. It will also help make sure that all families are helped, because their Black and Hispanic populations have a higher prevalence of dementia, but they're less likely to receive a timely diagnosis, have more unmet needs, and be more likely to have high caregiving demands. So it's important that this model be continued for the duration. It's just starting this year with some providers. Additional providers will come on board next July. And it's important that the learnings and the data from this model are shared within the model, the providers that are participating, but also beyond. And if it's successful, expand that model in Medicare. And for example, don't limit it to just caregivers of people with dementia, but share the learnings and apply the learnings in Medicare and in caregiver support policy more broadly. It's also an opportunity to show the return on investment for supporting family caregivers in Medicare. And again, policy changes and things in Medicare can also drive changes beyond Medicare. Thank you.
Thanks so much, Rhonda, for that overview and recommendations, really underscoring how we can continue to advance Goal 2 of the national strategy. And I want to now turn it over to our colleague and someone who knows these issues so well, Sandy Markwood, President and CEO of US Aging.
Here we go. Thank you so much, Jason. And it is absolutely an honor and a privilege to be here with you, with the RAISE Council, with the leaders of ACL on this important issue during National Caregiver Month. In saying that, as we look at Goal 2, looking at advancing partnerships and engagement, looking at the importance of being able to address the needs of older adults and caregivers. I think if we need to just advance the slide would be helpful as we're looking at from Goal 2 to Goal 3. When we're looking at strengthening services and supports for family caregivers, what's key and critical is the reauthorization of the Older Americans Act. The Older Americans Act, and embedded in the Older Americans Act, the National Family Caregiver Support Program, which was added to the Act in 2000, is really the national commitment to support older adults to age well where they want to age, which is at home and in the community, but also at the same time to support their essential caregivers to be able to ensure that they can age well at home and in the community. And given the demographics of the increase in this nation's aging population, and along with that, the increase in the number of people who will be caregivers to support older adults, as well as people with disabilities, and as has been pointed out, people across the lifespan. It is really critical when we're looking at an aging population that we authorize and we also appropriate increased funding for the Older Americans Act, and through that, the National Family Caregiver Support Program. I want to point out that the Older Americans Act actually expired this fall at the end of September, and that doesn't mean it has gone away. But as long as it continues to get appropriations, the act will still be in place, but it will not be modernized to meet the needs of older adults and also their essential caregivers. So when we look at the reauthorization of the Older Americans Act and subsequently increased appropriations, it's really key to implementing the RAISE strategy. It's critical to increasing momentum of all of the RAISE initiatives. To sustain this important effort and to continue to inspire the commitment and passion on RAISE at all levels of government, but most importantly, also in the community and with families and caregivers. So when saying that, I'd like to specifically just highlight some of the Act on RAISE initiatives around the Older Americans Act reauthorization. And I want to start out, some of these are really enhancing some of the points that Jason made at the beginning of the session, which is really increasing funding for the National Family Caregiver Support Program, which is an incredible program, as I said, enacted since 2000. But the appropriations for that program have not kept pace with the number of family caregivers who are providing this essential supports. In saying that, what we know with the evaluations of the National Family Caregiver Support Program, that the services provided by the National Family Caregiver Support Program, whether it be support services, education, important respite programs, what we know from the caregivers who has participated in these programs, it helps them to keep their older adult, their loved one at home and in the community years longer because they're getting that essential support. So increasing authorization for the National Family Caregiver Support Program is key and critical, but also increasing authorization for another part of the Act, the supportive services part of the Act, which is Title 3B, which really provides services such as transportation for older adults, primarily medical transportation, in-home supportive services, looking at home modification, all of the different services and supports that are necessary for an older adult to remain living independently and safely at home. And by increasing support for those services, it ends up also helping the caregiver to be able to provide that safe and secure home for that individual to age well. So it's increasing funding for the National Family Caregiver Support Program, but also for the supportive services that enhance and support the older adult to live well at home. And in addition to that, there is another section of the Act, which is really targeted to supporting Native American aging programs and the caregivers that are part of that initiative. And looking at the fact that as we look at Indian elders who are living on the reservation or living outside of the reservation, that they need support as well. And that is actually a separate part of the Older Americans Act. But just like the National Family Caregiver Support Program in general, it is woefully underfunded and needs to have increases to be able to meet the specific needs of caregivers of Indian elders who also face some additional obstacles just in the fact that oftentimes people are living in either very rural or frontier or remote areas. So even connection points like transportation, meal delivery, all of this is an enhanced obstacle that needs to be overcome, and funding needs to be there to ensure that they can be overcome. So funding is key and critical, but also ensuring that the Older Americans Act reauthorization extends authorities and funding for the RAISE Family Caregiver Act and the National Strategy to Support Family Caregivers to advance cross-cutting and national efforts to improve supports for family caregivers, what you do and why you are so important. And in saying that, it's reauthorizing and extending the sunset date of the RAISE Family Caregiver Act through the Older Americans Act to ensure that you as national leaders continue to update and improve the national strategy on a biannual basis. The RAISE strategy is an opportunity for us to, it's a dynamic opportunity to us to meet the needs of caregivers over time. It was never intended to be a one and done, and you all have invested so much and have increased the momentum and the visibility of caregiver issues in this country, and it needs to continue. But also guaranteeing the continuation of funding for activities of national significance, which were really enacted by ACL as an effort to be able to really take the national strategy and, to the extent possible, to be able to form opportunities and partnerships and collaborations among national organization and others to be able to ensure its implementation. And these are efforts around making sure that we can raise awareness around consumers, looking at innovations in family caregiving, looking at evaluation of family caregiving program, a whole range of issues that ACL invested in. And that needs to continue, just like the RAISE strategy needs to continue, and this council needs to continue to ensure that we are meeting the needs of not only today's caregivers, but also tomorrow's as well. And we need increased funding to be able to meet those needs as the number of caregivers in this country increases. Thirdly is really looking at ensuring that the Older Americans Act includes opportunities to expand and also enhance data collection efforts about the needs of family caregivers, to find out more about those needs so that we can have strategies in place that really meet those needs and ensure that we are improving and enhancing our program supports to meet those needs as well. So as part of that is looking at renewing requirements to advance the adoption of evidence-based caregiver assessments through the Older Americans Act service delivery, so that we're really assessing caregivers' needs so that we can adequately be able to respond to them. And also increasing investments in research efforts. And in the Older Americans Act, we've been pushing for increased funding for a new title, a Title IV that had been in place for years, but we really want to re-energize that title on research demonstrations and an evaluation center to identify the return on investment, the ROI of caregiver support for unpaid family caregivers. By doing that, by having that research in place, by having that data, that gives us more important ammunition to go to Capitol Hill to get the increases in funding that we need for the Older Americans Act and the National Family Caregiver Support Program. And finally, looking at exploring policy opportunities to strengthen state, area agency on aging, and service provider coordination with public health. Because what we understand, and we know that caregivers are not only the backbone of the long-term care system in this country, we know how critical they are to ensuring the health and the well-being of the people that they are providing critical services to, but also their own health and well-being. So looking at caregiving as a public health initiative and a priority, and ensuring that the Aging Network can be partners with public health to address that. There are so many other issues that we could address through the Older Americans Act, but as I said, it's up for reauthorization. It was up for reauthorization in 24. We are hoping that it could possibly be addressed through the lame duck session this year. But if not, we're going to be beginning our advocacy efforts all over again with the next Congress, and we'll need your support. Thank you.
Thanks so much, Sandy, for that overview. I want to turn it over next to Natalie Keene, Director of Federal Health Advocacy for Justice and Aging, to talk about the critical support and investments in home and community-based services that we need, and recommendations for continuing to advance that through the national strategy. Over to you, Natalie.
Thank you so much, Jason, and thank you to the council members and our hosts today. It's wonderful to be with you all. As you've heard, access to timely support is really critical to keeping people with disabilities and older adults at home. And access to paid caregiving is critical to support family caregivers in this effort. And Medicaid Home and Community-Based Services, or HCBS, continues to be the primary payer of this care in our country, and it's the only source of paid coverage for people with the lowest income and resources. Unfortunately, access to HCBS is not guaranteed, even for those who qualify. So we do have recommendations that we would like to see incorporated here, both for the administration and legislative action to really expand access to Medicaid HCBS. First and foremost, increasing funding for HCBS. We want to ensure that states can continue to build on the investments they made under the American Rescue Plan Act, where they received enhanced funding for their Medicaid HCBS programs, and much of that funding went to support the workforce and other innovations that really support family caregivers. Also, we want to make sure that we're supporting states to expand access to respite care under Medicaid, both through existing authority that states have, and then also, as we're looking to Congress to expand funding and access to HCBS, making sure that respite care is made a state plan benefit that every state is required to provide. We also are supporting expanding the requirement for caregiver assessments that's already included in Medicaid 1915I HCBS state plan options. We want CMS to expand this authority to all Medicaid HCBS authorities and provide training and technical assistance to help states with implementation of this. Also, we have recommendations for removing barriers to HCBS. So yes, there are proactive things we need to do to expand HCBS, but also we need to remove as many barriers as possible, both in terms of supporting states to expand their eligibility for Medicaid and for HCBS services in particular, and raising awareness of these programs. Public education is definitely necessary to make sure that family caregivers and people who need these services know about the Medicaid programs in their states. Also, we want to make sure that people are able to get access to HCBS right away when the need arises. This is a really big barrier and often a driver of putting people unnecessarily into nursing facilities because they can't get the paid support they need at home right away. And so we really encourage CMS to work with states to implement presumptive eligibility for HCBS and appreciate and encourage CMS's work on promoting provisional plans of care, as well as improving things like discharge planning from hospitals. So I know this gets really technical quickly when we talk about HCBS, but we think there are some important opportunities and ways, to raise, to support family caregivers through the Medicaid program. I'll turn it back to you, Jason.
Great. Thank you so much, Natalie, for underscoring the importance of continuing to invest in services and supports and recommendations and ideas, I think, to continue to advance that. And I also want to recognize in the chat, Jill Kagan, your really important recommendation, which we completely agree with, the importance of access to respite support and the National Respite Lifespan Care Act. And along those lines, you want to talk about the importance of investing in the workforce. And with that, I will turn it over to my colleague, Tori Cross from Caring Across Generations.
Hi there. Thank you so much, Jason. As Jason said, I'm Tori Cross. I use she, her pronouns. I'm the Associate Director of Federal Policy and Government Relations at Caring Across Generations. I know that there will be a full panel focused on the direct care workforce, but just wanted to touch briefly on the direct care workforce and how critical it is, both to supporting disabled folks and older adults and also to supporting family caregivers. We will talk a bit more under Goal 4 about it, but under Goal 3, under Outcome 3.9, there is quite a focus on having an agile, flexible, and direct care workforce. As folks may know, the direct care workforce is one of the fastest growing occupations in the nation, and it will continue to be so because of the rapid speed of the aging of our population, as well as because disabled folks of all ages are in deep need of home and community-based services. I think we can go to the next slide. Thank you. And I believe we can pass it to the person doing the first recommendation.
Sorry, I took this out of order, so I was just realizing.
That's okay.
That.
No,
we'll
that's
come right back
okay.
to you, Tori. I appreciate the context and the setup. And we'll go back to Rhonda as we talk about Goal 4, ensuring financial and workplace security for family caregivers with a specific focus on Outcome 4.1. And over to you, Rhonda. And I know this is a topic getting lots of visibility right now.
Yes, thank you. Thank you very much, Jason, and thank you, Tori, and again to the council. So family caregivers face financial challenges, and they need relief from those challenges. And nearly 8 in 10 family caregivers incur out-of-pocket costs, caregiving costs on average over $7,200 annually in caregiving related expenses, which averages on our to about 25% or so of their income. And I will note that family caregivers and others who are providing care for veterans spend on average $11,500 out of pocket from their personal income on caregiving each year. And nearly half of family caregivers have at least one financial setback, such as using their personal savings, cutting personal health care spending, reducing retirement savings. And too often, family caregivers leave the workforce and they reduce their hours due to their caregiving responsibilities, which means they're losing income, retirement savings, benefits, and career mobility. I'll also note that Hispanic, Latino, and African American Black family caregivers face greater financial strain. So as part of the Act on Raise's recommendations here, really the importance of reducing caregivers out-of-pocket expenses through tax credits and support for bipartisan bicameral legislation such as the Credit for Caring Act, which those of you who are in DC may be seeing some ads around that this week or so. Congress has a perfect opportunity next year to enact the Credit for Caring Act as they consider tax legislation to address expiring tax cuts. Caregivers need financial relief. The Credit for Caring Act has been introduced in the House and Senate, in the House by Representatives Mike Carey and Linda Sanchez, on the Senate side by Senators Bennett and Shelley Moore Capito. It would help eligible working family caregivers offset a cost of some of the caregiving expenses, such as a home care aide, adult day services, home modifications, assistive technologies, respite, transportation. An important point is that eligible family caregivers can be assisting loved ones of all ages. So whether you're caring for a child with a disability or an aging parent or someone else, it's care across the lifespan. Caregivers would receive the credit, if the person they're caring for meets certain functional and cognitive limitations or other requirements that are certified by a licensed healthcare practitioner. They would document the qualified expenses. And after paying the first $2,000 in qualified expenses out of pocket, the credit would be a 30% of qualified expenses that the caregiver pays, up to a maximum credit amount of $5,000. Phases out at higher incomes. And the bill would also help caregivers who are caring for someone who's not a dependent or someone who doesn't live directly with them. It has the support of over 100 organizations, including a lot of the organizations that you've seen listed on the Act on Race Steering Committee. Organizations like the Healthcare Leadership Council as well, the ERISA Industry Committee, National Multiple Sclerosis Society, American Heart Association, Michael J. Fox Foundation for Parkinson's Research, National Association of Self-Employed. A lot of different organizations and stakeholders support the legislation. So we encourage the council to include this in the next version of the strategy, and again, requires congressional action. Thank you.
Thanks so much, Rhonda, and we'll turn it back over to Tori.
Thank you, Rhonda, and thank you, Jason. As I mentioned, I'm Tori Cross. I'm at Caring Cross Generations, and really wanted to talk about under outcome 4.1, expanding opportunities for family caregivers to receive payment through increased investment in Medicaid and Medicare programs that support consumer-directed care, which will address barriers related to awareness and eligibility. As Rhonda and some of my fellow committee members have said, family caregivers provide more than $1 trillion in unpaid caregiving, and simultaneously unpaid family caregivers experience significant workforce and earning losses. This is especially true for caregivers who are people of color, who also experience higher financial strain and impacts as a result of providing care than their white counterparts do. For these reasons, we do believe it's critical to expand these opportunities for family caregivers to receive payment. Expanding opportunities for family caregivers to receive payment through Medicaid and Medicare will also overlap with that outcome 3.9 on building an agile, flexible, and well-trained direct care workforce that is available to partner with and support family caregivers, both because family caregivers can themselves then be paid to provide care, and that reduces strain on the overall workforce. And because consumer-directed care provides a critical opportunity for care recipients to have caregivers who meet their cultural and linguistic needs, thereby supporting health equity and culturally competent care. Self-directed care, as another word for consumer-directed care, also results in positive health outcomes and caregivers experiencing an improved quality of health. Those positive health outcomes are both for caregivers and for people who receive care. Consumer-directed care is a critical tool to ensure that independence and dignity for disabled people and older adults is protected and enshrined for folks receiving care. So we have two specific recommendations for expanding opportunities for family caregivers to receive those payments. At present, hiring of legally responsible relatives remains entirely prohibited within Medicaid state personal care options. CMS can eliminate this restriction, which limits the ability for states to streamline and align policies within their HCBS programs. And this change could increase both the quality of efficiency of care in states and nationwide. Additionally, CMS can provide technical assistance to states to support outreach with regard to self-direction, with a focus on expanding reach within underserved communities, especially as I mentioned, self-direction can be helpful for ensuring that cultural and linguistic needs are met, especially for care recipients who are people of color and for people where English is not their first language. So thank you so much. And I'll pass it back to you, Jason.
Great. Thank you so much, Tori, and to all of the members of the Act on Raise campaign, who highlighted different opportunities to strengthen and advance goals and specific outcomes outlined in the national strategy. Our hope is, and you can advance to the next slide, that between the structural recommendations I outlined at the beginning and then these more specific goal and outcome-based recommendations, that there are rich ideas and opportunities to continue to strengthen and evolve the national strategy across the different pillars of the council, of Congress's role to support these goals, and then also federal agencies' role in supporting and advancing this goal. I think one of the most beautiful things about the national strategy is that it reflects the beauty and diversity of the caregiver community, really stretching across the lifespan, across different challenges and opportunities, which underscores the need to continue to take a multifaceted approach, but with clear recommendations and goals across government, across communities, across states and beyond. And I think it's in that diversity of stakeholder engagement and ownership that we could really advance this moving forward. And it's going to continue to take the multi-sector collaboration across the caregiving community, across philanthropy, the private sector, states, federal stakeholders, to really continue to build on the progress made and to realize the true potential of this strategy framework and the connectivity that it's created between all of us and beyond to drive action in support of family caregivers. We've only touched on, I think, even though it sounds like a lot, I think it's still the tip of the iceberg in terms of the things that we could advance collectively and the policy and actions that are needed to truly recognize family caregivers, from the Lifespan Respite Care Act, as Jill has mentioned, to paid family and medical leave, to strengthen resources at the agency level. There's so many additional priorities that will be needed to continue to advance the strategy. But we hope that this provided a clear framework of some specific opportunities to move forward. And with that, I'll turn it back over to Jonathan to help facilitate a Q&A. Thank you.
All right. Well, fantastic. Just a ton of great information, actions, strategies, just wonderful. So now we're going to spend the next little bit of time on really opening it up to our council for questions and discussion through our panelists. And I know we could end up spending hours upon this, but let me start the question just for some thought-provoking start with a thought-provoking question. A lot of us, so we're all in this together. There's just a ton of great information that's been shared with us. Many of us are with non-government organizations. For those specific ideas for actions beyond the federal government or Congress, can our panelists spend a minute or two just to recap or give us a sense of what you feel we should be doing more of, or how we could take actions to help family caregivers feel the impact while the government policy work is happening? So let me open it up and see which panelists, Jason, yourself, or others, if you want to take that as a lead.
Sure, I'm happy to, and then welcome others to weigh in. I think there are a couple of key areas. One is from non-federal perspective, non-congressional perspective, you see and live the gaps that exist. So continuing to articulate those gaps, and I think that kind of underscores one of our recommendations around what are continued specific policy opportunities that you would like to see. I think we see that in the initial strategy, that about a page and a half, a policy table, continuing to develop that around where you see opportunities for continued leadership from those other sectors, from federal partners and congressional partners. I think that that's one area, to bring those gaps further to light. Second is to continue to tell the stories that bring, these actions to life and bring those to the table. I think, Jonathan, you've done an amazing job at this in centering and reminding us that this is across the lifespan. I think continuing to do that work will really be important as the North Star for your federal agency partners and for congressional partners to understand how we need to think about this across that care continuum.
Yeah, that's awesome. Greg, you've got your hand up?
Yeah, I just wanted to build on that great question, Jonathan, to see if Jason or any of the panelists can speak to get a little bit more specific about what can some of the other sectors that the national strategy speaks to do to advance the issues that are important to your group, to the work that you are doing. For example, what can states do? What's in it for the healthcare delivery system? What's in it for, what can human services delivery systems do? Employers, all of the other constituencies and all of the other sectors that are mentioned in the strategy that are not Congress, that are not the federal agencies. What are some ideas for how we can advance some of those issues that are important to your group, the Act on Raise coalition?
Sure, I'd love to open it up for, I see Rhonda raise her hand. Our coalition is focused on driving federal level action in support of the national strategy. So I want to make that clear. We have to have specific goals to be effective at our kind of scale. We're lean and mean, but that doesn't mean that collectively the voices and stakeholders at the table don't have those recommendations. And I see Rhonda with her hand up, and I'll turn it over to her.
Well, thank you very much. Just going back to one of the issues we talked about a little bit earlier, the caregiver training services in Medicare. That's a Medicare policy that CMS put out, but the implementation of it is very much on the ground in communities with doctors and nurses and other healthcare professionals to offer those services to family caregivers, those training services. So it's important that folks and providers and health systems and whatnot take advantage of opportunities that are there from policymakers, whether it's federal agencies or Congress, to implement those to help family caregivers on the ground day to day. So provide those caregiver training services, whether it's in medical nursing tasks or help with daily activities. Share the word among others so that people know about them. Help educate caregivers, educate providers, etc. So that's a very concrete example. But people in their day-to-day lives, in their sectors, when you see the opportunities and gaps, raise your voices, as Jason mentioned, and those who are in a position to take action to address issues, look where you in your day-to-day lives, in your professional role, whether you're in a hospital or a health system or somewhere else, what you can do to better support family caregivers, because you may benefit from that support one day yourself as a family caregiver.
Fantastic, Rhonda. Thank you very much for that. I've got other questions going in my mind, but we got a couple of hands too. So Natalie, why don't you take the lead in the microphone?
Thanks. I was just going to add that, Medicaid is a state federal program, and a lot of the innovations and opportunities for states to support family caregivers through their Medicaid program, a state could choose to do that on their own. We are asking for CMS and the federal government, and in many cases, Congress, to fund those innovations, but there is a lot that states can do on their own to expand their Medicaid programs. For example, they could expand access to respite care in their Medicaid home and community-based services programs. And we find a lot of success when state advocates and people locally are asking their state to make those changes. It can be a really powerful and helpful.
Fantastic. Oh, go ahead, Jason.
We'll just add just a quick and I'd say the same thing can be applied to Medicare Advantage plans, right? Sort of from a private sector perspective, could also adopt those respite services as benefits. So I just wanted to double click that.
And I'm going to take a moderator's prerogative here for a second and hop in for a quick question, and then I'm going to go to Jody. But so I know our organization works with state level Medicaid directors and things. How, from the panelist perspective, the federal strategies and the federal direction that's happening, how do you guys feel is moving to the different state Medicaid directors, so that when we're with our local teams working with state Medicaid directors, how informed do you think they already are, and how embracing do you think they are, so that these conversations, we're not the ones teaching them about this. This is something that kind of builds on the conversation that should be already happening. Where's your perspective on that?
Yeah, this Natalie again, and maybe Jody wants to weigh in here too, but I do think this is something that state Medicaid directors are thinking about. And it wouldn't be like, coming to them with something they've, never heard of or are unfamiliar with. But they have a lot that they're dealing with in their state. And so a role that we can play from this level is sharing best practices from other states. What are some innovations that you see another state doing, and, making sure your state or other states know about that.
Yeah.
Right.
And
All
I
right,
think there's-
Jody. Oh, go ahead, Jason. Sorry.
I was gonna say, I think that's changed. I think there's like, well, it's growing, I think is part of what, and I think that's happening more and more as we think to one of the things that the strategies help to do is catalyze cross-sector partnerships, including between organizations on this Zoom, and also philanthropy. So now we see advancing states, NASHB, doing more in this space to create that awareness and to build that capacity. So I think, progress is happening.
That's it. All right, Jody.
Yeah, and I just kind of wanted to build on like 3 parts of that question and conversation. To your original point, Jonathan, about what organizations can do that are non-federal and not in that realm. I think many of the things you've heard is that really education is so important. I mean, we all know about the strategy's existence. We all know what parts of it are and what it focuses on, and we're looking to kind of build it and continue to kind of build that track as we're on the train. But I think we shouldn't assume that everyone knows about it, right? So I think even just elementary conversations and sharing of the strategy itself, the fact that it exists, sharing a link to the website on the ACL, sharing a link to Act on Raise, and all of those things that we are very familiar with aren't widespread, as they could be. So I think to Jason's point, it's continuing to grow and it's continuing to get on people's radars. But I think that that's a really, really important point, is just education about the existence, so that people realize they can ask about it and they can think about it. And they can take advantage of some of the things and the resources even within that strategy that exist. I think, to your point about working with the state Medicaid directors, I think it is on a lot of radars. We continue to kind of push out things from ACL and from CMS to kind of do our part to create awareness. To Jason's point, there was a good panel at the annual HCBS conference this year that really concentrated a lot on the federal actions and Act on Raise campaign and what folks at NASHB are doing to kind of get information out. So I think, we're definitely all in this together, and there's a role for so many people to play, but continuing to educate people about its existence and the importance of it is going to be key.
I know that there are lots of Medicaid director kinds of groups and meetings and things. Do you know if this is on their agenda at some of the regular meetings that they're having?
Well, I am not in a lot of the meetings with the National Association of State Medicaid, or the National Association of Medicaid Directors. I think there were some of those folks that were at the HCBS conference, and they certainly work closely with their state operating agencies. So I think it is. But I would encourage everyone who was, with any of those groups to mention it if you're curious, just to make sure that, and to understand what people are kind of looking at and where they're focusing efforts as they kind of look ahead.
Yeah, excellent. All right, I got more questions, but Sandy, let's let you get in here. You've got your hand up.
Here I am. Yeah, well, I think, the one thing, Jonathan, that you raised is, looking at across the board at advocacy issues. And I focused on the Older Americans Act, but I think it's really critical from a caregiver coalition perspective for groups that are supporting youth caregivers that support older adult caregivers and vice versa, so that you're hearing non-traditional voices coming to the administration, coming to Congress, saying caregiving is a lifespan issue, and we need to look at it and advocate for it that way. As far as Medicaid and state level issues, I would say that area agencies on aging are more and more contracting with healthcare. And one of the major areas that healthcare payers are looking at is caregiving training and support. So I think that there are opportunities there. And then finally, when we look at the RAISE recommendations, it's also not discounting the local level. Looking at actions that can be taken in counties, in cities, and we operate Dementia Friendly America, looking at supporting caregivers of people who are on the dementia journey, and that is entirely a local effort. So it's just looking across the board, all levels of government, but also ensuring that we continue to have a spotlight on the community.
Yeah, that's fantastic. Just coincidentally, my wife works here in Phoenix with an organization that has a phenomenal dementia campus that does dementia training that is really a kind of just should be a jewel of the country, and something that hopefully other communities will be able to replicate, because it's bringing together community members to learn more about caregiving, respite, and just how to care for elder cares with dementia, et cetera. Those take, one of the barriers that, there's a lot of things that can be done and I think we're trying to get information out, create awareness, telehealth, kinds of issues, but there's a lot of things that take brick and mortar also, to be able to provide respite services and some of those things. And those are really about, Greg, I think you brought up the sectors in terms of, there's also things like health department licensing and regulations, and trying to link those to funding, and just trying to ease the system a little bit so it's not so bureaucratic, so that we can help get some of these kind of programs more open and available. So I don't know, I throw that out to any of the panelists. This is, we've got the panelists, but also the other council members. I mean, please jump in with your thoughts or questions. Jill Kagan in particular, I know you've got, I love the work that you're doing. And so if you want to bring in any of your voice, this is an opportunity to kind of do that too. Carol.
Yeah, I'm going to try this without the camera. Can you hear me?
Yes.
Oh, excellent, excellent. I'm curious for the panelists, the difficult position or the people that the AAAs normally.
Oh, unfortunately, Carol, we're losing you again.
Serve are those that are too high in again. Okay.
I think we are, unfortunately, Carol, I know she's in.
Okay, I'll stop.
If you want to put your question or thought in the chat, maybe I can read it out for people, or we can try and bring a little bit more attention that way. How about some other questions?
I'm putting it in the chat. I'm putting it in the chat.
Okay, I know Shira has a question for the host and panelists. It says, have a question regarding IHSS wages in California. Is $19.72 per hour, but it needs to be higher, like 35 to 40 on a state, federal levels to be to the standard of living, and many caregivers hold multiple jobs to make ends meet and find reliable caregivers. I can definitely echo that on my side for children caregiving as well. So this is, I think, Shira, you're asking more about funding and wages. And I also think, those that want to talk about this, it's not only wages, but it also is just caregiving as a career path. People need to really recognize that this is a wonderful, emotional career path, and that we want to give people a chance to actually have a livable wage and to want to be able to deliver this kind of care, because there's a lot of amazing people out there that want to do this kind of work, but just can't afford to do it. So panelist reactions to those, how about take that topic and talk through that?
Yeah, I wonder if Tori or Natalie has a comment on that. I think clearly there's one of the and we're excited for the second half of this focused on the direct care workforce, but really that intersection between direct care and family care is really critical to look at. One from a wage perspective, from a training and engagement perspective, and then also to your point, Jonathan, that opportunity to look at what career paths look like from family care into direct care. And that's where, around really thinking about this through a workforce issue and an economic security issue where goals, 3 and 4 really overlap, are around issues like consumer directed care, where you can create pathways for family caregivers to be more formally recognized for their roles through payment, and through, continued engagement and training as a potential opportunity for economic inclusion, but also through sort of workforce development over the long term. I see Natalie came off camera, so I will turn over to her.
This is Natalie with Justice and Aging. I don't have much to add. I think the point is well made. We need to raise these wages and make them good jobs. And Congress needs to increase funding for Medicaid to make that possible in every state, so that it's not, state by state. But again, another opportunity for some states to be able to act in the meantime. And just to clarify, the acronym IHSS is In-Home Supportive Services. It's a Medicaid program, state plan benefit in California.
Thank you. So I guess as we were talking, I kind of went back to the point of this panel was really talking about the vision. And I come from a business corporate career before I kind of got into this public health world in the last few years. And so when I think about vision, I think about what is our end goal? If we had a magic wand, what do we really think, panelists, if we do all the things that we're talking about, how will family caregivers feel this in the next 2 to 3 years? What will be the tangible actions that you think can actually filter all the way through the conversations, the policies? What would you want to realistically have them feel in the next couple of years? And then I guess in the same question, same topic, obviously we just had an election. I know certain people on the panel that are actually with the federal government are not allowed to comment on their thoughts on that, which is fine. And I don't want to get into the political realm of conversations, but we're going into unknowns. And so just if anybody wants to kind of share, do you feel like, are there areas where our future is brighter because of some of the changes that are going to happen? Or do we feel like we have even increased challenges in areas that would be an opportunity to kind of maybe tackle some of that here as well?
Jason, if it's okay, this is Tori. I'm happy to start. I'm sure there will be many thoughts. To your first question on thinking about the point, are really thinking about the vision in the next 2 to 3 years, I think it really is honed in on by some of what those goals are. I think we want family caregivers to frankly have more money in their pockets is a big one. I think we want family caregivers to be experiencing less stress and pull at the edges. And I both mean that financially, but I also mean that emotionally and in their well-being, and in terms of being less isolated, which is a really common family caregiver experience, is feeling very isolated from other communities and including from coworkers, et cetera. And so really want to reach a point where family caregivers are more financially stable, are more able to make ends meet, are able to keep their jobs if that's what they want to do, and also are able to be paid to do care work if that's their preference, and if that's the preference of people who are receiving care. And so I think a lot of these actions are movements in that direction, where being a family caregiver isn't something that will cause so much stress and so much difficulty, economically, interpersonally, and emotionally. In terms of thinking about kind of where we go from here with this new landscape, I think there will need to be quite a lot of focus on defending what we do have, defending the Medicaid program and the HCBS program in particular, and ensuring that we are working very, very hard to both to grow from what we have, but also not to lose any of the gains that we have made thus far. And so I think there will be a large focus on, we have to be, I'm going to say it 10,000 times, we have to be defending Medicaid, we have to be defending HCBS in particular. And that includes the full breadth of Medicaid, because harms to any part of Medicaid inherently are harms to people who receive HCBS. Cuts and caps on Medicaid are going to catch people who receive HCBS, are going to harm direct care workers. I know that, of course, I'm certain the direct care worker panel will touch on this, but approximately 40%, I believe, of direct care workers themselves receive public benefits, including Medicaid, for their own health insurance. And so to make sure that we are protecting the full gamut of folks who are impacted by HCBS. So that's the care recipients, that's the care workers, and that's the caregivers. We have to defend the entirety of the program. I will step back off my soapbox if anyone else.
Yeah,
would like
no,
to go
I,
next.
amen. I'm right there with you. I completely agree. All right, Sandy, you got your hand up.
Yeah, following, whoops, sorry. Up, I'm back. I would just, I'm building on what Tori said, but I think it's really incumbent upon us to we've made the human argument for caregiving, and we've done it well. But we need to make the economic argument. And as Tori, as you said, it's making that argument around the economics of keeping people at home and keeping them well at home. It's around the economic argument about keeping their caregivers in the workforce by supporting them and services and supports, and the economics of direct care workers and the contributions that can have to society. So I think as we're looking at this, that yes, we need to, maybe defense is part of the discussion, but I also think we have the ammunition to take this on the offense by making the economic case for caregiving.
I completely agree. On my side, on medically fragile children, we can really compare to the alternative is emergency room hospitals. And that is the last place you want to end up having a child go in for, so the parents can get some respite. It's the wrong environment. It's insanely expensive. And we're trying to build that case also. Rhonda, you've got your hand up.
Thank you. I wanted to build on in response some of the responses to Jonathan's question, and also speak to some of Carol's question in the chat as well. Caregivers, saving them money, like a family caregiver tax credit, saving them time, which goes to the stress and the strain on caregivers emotionally and things like that. One way to help save them time and make it easier to navigate is reducing red tape for family caregivers when they're interacting with like Medicare, Social Security, Medicaid, et cetera. There's a bipartisan bicameral bill, the Alleviating Barriers for Caregivers Act, to help reduce red tape for family caregivers in those programs. And making sure that caregivers can access support, that all caregivers can access support. And to some aspects of Carol's question, obviously programs that were talked about, like the Older Americans Act and the National Family Caregiver Support Program, are important. Looking at, again, ways Medicare can support family caregivers. There are opportunities there, as we've seen some and heard about some today. So I think looking at different ways and building on what is there and looking for new opportunities in some of the ways that we've talked about today and otherwise as well.
Great. And so I don't, those are great points. Carol, I think also had another question, which I don't think you were exactly addressing, which is, can the panelists address ideas to support middle-class caregivers who don't qualify for Medicaid and can't private pay? They're kind of in that middle group.
Can you repeat that, please?
Sure. Can the panelists address ideas to support middle-class caregivers who aren't qualifying for Medicaid and can't afford a private pay. So they really have no options. Where do they go, or how do we help them out?
I think I'm happy to jump in. I think there are a couple areas. One, continuing to, and I think this also fits into your question, like what are opportunities within the next 2 to 3 years to really continue to ensure that family caregivers get more support today than they did yesterday, right? Like, how do we continue down that path? And I think one is, caregiver tax credit, the way it's structured, would support that middle class and is really structured in a way that would phase out at higher income levels. So a really targeted way of putting money in people's pockets. Two, a continued investment in the Older Americans Act and expanding available services. Respite services, I think, are another opportunity. Looking at the current home health benefit and thinking about how do we build on that through the Medicare program to be a supplement to Medicaid-based supports for folks within that middle income category. That's an underutilized benefit on the family caregiver side in terms of accessing support through a direct care worker, even pathways for family caregivers to take on that role as the provider of consumer directed care through Medicare. So I think there are opportunities. Again, it's going to take the ecosystem where we are continuing to keep in our North Star that vision of comprehensive investments in the infrastructure that we need to make care more sustainable, while continuing to make progress on incremental opportunities like a caregiver tax credit, like easier to access benefits through Medicare and Medicaid. And it really is that combination. There's no one silver bullet. It's going to continue to have to pull at the levers of change over time, seize on opportunities, but not seed on ground. And I think that's going to be really critical as we go into the new Congress and administration.
I thought that was very well said. There's another question that I think probably feeds into that same kind of line of thinking, but specifically a question was asked about caregiver programs specifically for African Americans and Hispanic communities. I'm sure a lot of what you just talked about, Jason, probably has a lot of implication for those particular subgroups as well.
Absolutely. So and it's welcome, Sandy, to come back, but the Older Americans Act program is a great example of a program or set of programs to support caregivers across, race, ethnicity. I think we can do more to ensure that needs are met. And I think this is where, as we look at reauthorization of the Older Americans Act, a greater emphasis on ensuring that assessments that are utilized through Older Americans Act programs and the National Family Caregiver Support Programs are taking into account cultural and linguistic differences. That's really critical in order to ensure that we get the appropriate resources to the appropriate communities. At the same time, thinking about, not limiting programs available through initiatives like Older Americans Act to evidence-based practices only, because so few of those evidence-based practices have been tested in linguistically and culturally diverse communities and have a wider aperture to also innovative-based practices or promising practices and programs so that we can ensure that there's some cultural sensitivity and tailoring, because we want to ensure that the dollars that we're spending are effective and reaching communities who need them the most. And I'm sure there's other programs. I don't know if other panelists have thoughts on that beyond what I said.
Jason, just to add in there, just to add in there is that US Aging, through a grant from ACL, has an innovations hub. And what we're looking at is collecting innovative caregiver programs and then also sorting them by the populations that they're serving. So happy, again, to share that with you all. But there are some incredible caregiving programs going on with the African American community in Detroit, in Chicago, but also with the Latino community, LGBTQ. So in looking at that and providing best practices, promising practices, to your point, Jason, it's not all evidence-based, because in culturally diverse communities, evidence-informed may be more appropriate. But I think the more that we can hold up those examples for replication, the more spread that we'll have.
Great. All right, I'm kind of leading off of a question that Lita in the chat had asked, kind of bringing us back to the health economic part of this, was asking if have there already been studies that anybody wants to highlight around how much OAA fund programs save Medicaid, or if other federally funded programs increase the family caregiver's ability to keep their loved ones in their own home and delay institutionalization? What studies, how do we help support that kind of movement to get more economic information, given how important that is? Greg, you got.
I can begin to speak to that, particularly from the perspective of the National Family Caregiver Support Program. I mean, that question is kind of the holy grail of family caregiver supports, is by supporting family caregivers, are we saving the system, whether it's Medicaid, Medicare, or any other publicly funded source of funding? Are we saving that system dollars? In the evaluation that we did of the National Family Caregiver Support Program now several years ago, we attempted to begin to get at a question adjacent to that, and that was, did the Older Americans Act program enable family caregivers to provide services and supports for longer periods, or to feel more confident in their roles? And so we have to keep in mind that this was specific to the recipients of the National Family Caregiver Support Program. So we can speak to that program. I don't know that how well we could extrapolate out to other programs, but it was found that respite services, when combined with caregiver education or support groups, tended to have a more significant positive impact on family caregivers' overall well-being and the extent to which they felt they could continue in that role. Now, that doesn't translate necessarily into saving dollars, but one could say that if the caregiver support program services enabled a caregiver to keep their loved one at home indefinitely, as opposed to placement in 6 months in a Medicaid nursing home bed, for example, that yes, the system would be saved money. But we did lay the groundwork with that. It was, again, a very small evaluation limited to the program. But I think there's opportunity, and as we look to, building out some ideas for future research and data gathering in an updated strategy, this is one of those areas where I think we have an opportunity to do that.
Fantastic. Rhonda.
I also just wanted to mention that Washington State, I think, has done some research that showing around their family caregiver support program and impacts on Medicaid spending and whatnot. And also going back to the guide model, that's an important opportunity within Medicare for the evaluation of caregiver support to caregivers of Medicare beneficiaries, and another opportunity again to show the return on investment and potential savings and things like that as well. So obviously that's longer term, but again, another important opportunity.
Fantastic. I'll raise my hand and just kind of make a comment. So our group, Children's Respite Homes of America, I was recently talking to a woman, a mom of a very complex child who's now 28 years old. In 28 years, I asked her, how have you gotten a break? How have you been able to just get some recharge, get some respite? And she laughed and kind of rolled her eyes and said, literally in 28 years, she and her husband have been attached to that young woman, that child, for 28 years. Only 2 days in 28 years have they gone off together to be able to get a respite stay. She had a conference in Scotland and he went to Scotland with her. And she was so nervous because not only is there not places, but they have to be places where parents are trusting of their child. Somebody needs to be able to care for the person to give that respite break. The other thought that I wanted to kind of throw out to the group, just for thought-provoking, is we often use the word respite, and respite has a spectrum of of services. So anything from respite is a few hours so that people can get caught up on errands, can catch a quick dinner together, maybe go see a movie or just breathe for a second. Our group is really focused on overnight respite, where the child is being cared for. And that really in a community can either only being, theoretically could be done in a home health situation or at a hospital, because there isn't a children's respite home in that community right now. And you really can't deliver that consistently in a home health situation. As much as we all want things to be done in the family's own home, because that tends to be where, the warm feelings are. And oftentimes people think it's less expensive. But how do you deliver overnight respite consistently for a couple of days, 3 or 4 days, or a week at a time in the family's own home? That becomes logistically very challenging with the terms of the nurses and the caregivers that you need to be able to rotate into that group. So without having community-based centers for respite, it just becomes, it's a whole different kind of part of the continuum that we should be trying to reframe and talk into the, add into the conversation. So anyway, for what it's worth, I wanted to just plant those seeds for people as well. So respite is not just respite. You can't, we need to better define the word respite and what does that really mean? Because, funding it at an overnight respite level is a whole different kind of respite, and it's at a much higher level of cost and expense also, but it's still way cheaper than using the emergency room at the children's hospital, which is not the right environment. So in terms of the health economics, that's where we're really trying to help kind of spearhead this conversation as well. All right, we have a couple of minutes left, so I really want to make sure, panelists, do you have questions for yourselves that you want to kind of flesh out? Any more ideas in particular? Jill Kagan, I saw, was throwing out some, obviously Nashby. Yeah, okay. Well, I think we've probably squeezed the questions and the thoughts out of the group. If that, any other last minute, we'll kind of call for last hands. Otherwise, I think what we'll do is we're getting close to time. We can just wind this down. And I think that Jonathan gets us back to the next step is just a breathing break for a minute.
Good afternoon, everyone. We are going to get started in a moment here with our family caregiver support and the direct care workforce panel. I just wanted to note before I turn it over to our moderator, Carol Zernial, that as a request to all of our speakers, when we were planning this, we had both panels submit reading material that we felt would be pertinent for our RAISE Council to review prior. And both panels felt so strongly within their reading material that the direct care workforce issue and all of the complexities around it be showcased. And they actually had the same publication that they both wanted, both panels, and that was Together in Care, published by PHI and the National Alliance for Caregiving. So I think that really speaks volumes about the unity of importance around this issue and our topic today. So what I would like to do is turn it over to Carol Zernial, who is our RAISE advisory co-chair, as well as the moderator of this panel, again entitled Family Caregiver Support in the Direct Care Workforce. And Carol, before I turn it over to you, again, if I can reiterate a very important housekeeping note, that is for the benefit of our ASL interpreters and for the folks that are all participating, please, we can ask our presenters to speak slowly. That would be very helpful. So Carol, the floor is yours.
All right, let me check. Are you able to hear me?
Certainly am, Carol.
Oh, excellent. Thank you so much. Well, I hope everyone enjoyed our break. I know all of us are working hard today and appreciate the time that you're investing in this. So we're going to be talking about the direct care workforce, and this is a huge over a lot of caregiver issues. We've got a large demand that's outstripped the supply. Direct care workers assist older adults, people with disabilities, fragile children with
Carol,
daily tasks such as dressing,
Carol?
bathing. Yes. So
I'm sorry,
yes.
Sean. I think what I'm going to jump in and ask you to do, if possible, is maybe take yourself off video. Just keep the
All
audio
right.
on and let's see
All right.
if
Oh,
that's
I
going to
was so
work, because you get a bit
optimistic.
choppy there. I know.
All right.
We'll see if it works strictly on audio. Okay, thanks so
Okay.
much.
Are you able to hear me now?
I am. Yes, go ahead.
All
Carol.
right, I will talk slowly and I'll leave the camera off. But we are talking about the direct care workforce. They do assist older adults, persons with disabilities, people caring for children with daily tasks such as dressing, bathing, and eating. And in addition, personal care aides also help with transportation to medical appointments, and home health professionals administer wound care. According to the Commonwealth Fund, the direct care sector is projected to add over 1 million new jobs between 2021 and 2031. This is more than any other occupation in the United States. But mounting workforce challenges, a growing population of older adults, and increased use of home-based care may make it difficult to meet this demand. So given these challenges, the RAISE Council may want to consider adding the direct care workforce shortage as an additional goal in the updated national strategy. We've had a lot of discussion around this. And as we assess the issue, we felt it was important to convene a panel well-versed in the scope of this challenging issue and one that can enlighten all of us, particularly regarding emerging trends in this sector. So today I will be moderating a panel of recognized national experts that include Rena Aurora, Director of Care Policy from the National Domestic Workers Alliance, Kevin Coughlin, Policy Initiatives Advisor, Executive, Wisconsin Department of Human Services, Robert Espinosa, who's the CEO of the National Skills Coalition, and I'm particularly pleased to be joined by our fellow council member, Keisha Scales, who will be offering her thoughts and insights regarding the panel's finding. Keisha currently serves as Vice President of Region Evaluation at PHI, an accomplished and respected organization in aging and disability workforce policy. So I welcome you all and look forward to your remarks. Robert, let's begin with you.
Thank you, Carol, and thank you, Jonathan, and everyone else. I really appreciate the opportunity to be able to speak to all of you today, and thank you to everyone on the RAISE Family Caregiving Advisory Council for both opening up this conversation about the critical role of direct care workers in our landscape among families and the kinds of support they offer. I'm going to be focusing specifically on the policies and the ways in which policy leaders can think about what an enhanced goal could look like that centers direct care workers and family caregivers. If I can just move my slides, I think I shared. The next slide, please. Thank you so much. So Carol offered a few points. Actually, the one before that would be helpful. Carol offered some important points about direct care workers. And for level setting, I just want to build on some of those ideas because I think they help set the foundation for what I'm going to be discussing in my remarks. But also they help us think about the ways in which we as leaders, whether we're working in policy or practice, can really think about valuing and supporting direct care workers in the context of family support. So as Carol mentioned, direct care workers by definition support older adults, people with disabilities, and those with chronic conditions. They span a range of occupations from home health aides to personal care aides and nursing assistants, and they work in a wide range of settings. I will, according to PHI research, there are about 5.1 million direct care workers in the US, and the majority are women, Black, Latinx, and other people of color, and about 28% are age 55 and older. So in many instances, we're talking about older people supporting other older people. This is relevant, I think, in the context of family caregivers. If we can move to the next slide, please. None of these statistics will be new to this council or to this conversation, but I think it's worth reiterating that there are millions of family caregivers in the US. A significant portion of them are under 50 and are women, and the act of family caregiving impacts caregivers' economic and health well-being, right? We also know that 24% of family caregivers care for multiple people. Now, one thing I want to state, just for the context of this presentation, is that there is incredible value in thinking about direct care workers and family caregivers in overlapping ways, right? These are not always mutually exclusive categories. Many direct care workers are themselves family caregivers and parents. About 31% have children under the age of 18, according to PHI data from 2022. And because of the existence of consumer direction programs, many family caregivers would be defined in workforce terms as independent providers, right? But I would pose that for the purposes of this presentation, there might be more value in thinking about these two entities as distinct entities, because I think there are numbers of ways in which policies and practices and other support can strengthen the direct care workforce as a means of supporting family caregivers as a sector. So, for example, if we think about it in the context of compensation, we might initially say, well, aren't they both entities that can be properly compensated? But if we look more deeply, we might think of a direct care worker and compensation in the context of workforce as a job, as a career, as ultimately a profession that could be ultimately supported by better training and credentialing, by multiple career ladders. These workers would be classified as employees, protected by labor laws and subject to structured schedules and professional standards, whereas family caregivers may be eligible for tax credits, stipends, or small grants to improve their compensation, but it's not the same thing as thinking about what a direct care profession and career can look like. And so my recommendations are going to be rooted in that assumption, however imperfect it might be. Next slide. We also know that direct care workers are enormously valuable, and they're enormously valuable to family caregivers in the sense that they offer both respite and support. And they're, of course, valuable to the millions of older people and people with disabilities who rely on them on a daily basis. They're also essential to the economy. When you think about the role, for example, that direct care workers play in supporting family caregivers so that they can remain employed, that is, of course, incredibly critical to the ways in which the economy functions and the ways in which workers in this country need that type of support. We also know that direct care workers can help keep families intact and might prevent early, costly, institutionalized care. According to Genworth's Cost of Care Survey from 2023, the cost of long-term care services has continued to increase from 1 to 10% in the last year alone. And it is the annual median cost of a semi-private room in a skilled nursing facility that remains the highest, $116,000, right? We also know that direct support professionals, as one segment of the direct care workforce, enable individuals with intellectual and developmental disabilities to stay employed. And so those are three critical roles that direct care workers play. Next slide, please. Unfortunately, despite the enormous value of direct care workers, too many direct care workers receive median hourly wages that place them in or near poverty. Also, many workers are relegated either by their employers or by the economy to part-time work. Workers have limited access to adequate training to both advance roles that would allow them to stay and advance within direct care, but also career pathways that would take them into other careers or other industries. And of course, the kinds of supportive services that all workers need, which are supportive services like childcare and transportation or their own long-term care. We also know that even though direct care is incredibly rewarding, the constant emotional and physical demands can lead to high burnout among direct care workers. All of this taken together means that turnover rates are incredibly high. For nursing assistants, anywhere from 100% to 80% among home care workers, according to two recent studies. And while there will be at least 1 million jobs, per Carol's points, new jobs that will need to be filled, when we take into consideration the number of job openings that will need to be filled because workers are either exiting the labor force or leaving direct care for other industries like retail or fast food as two examples, PHI estimates that between 2022 and 2032, there will be 8.9 million direct care job openings that will need to be filled. Next slide, please. My recommendations are focused predominantly on this principle, on this statement that is in the RAISE strategy. First principle that says, only through the development of a robust, well-trained, and well-paid direct care workforce can we ensure family caregivers and those they support have access to reliable, trusted, and affordable paid supports and assistance when and where they need it. And it's specifically rooted in the idea that the more that we support direct care workers in improving their jobs and in stabilizing and strengthening this workforce, the better care and services and supports family caregivers will receive. Next slide, please. The recommendations are also rooted from a policy perspective. So that's by virtue of my experience and my expertise, but it's also by virtue of recognizing that there is a big role for both federal and state governments to play in ensuring that workers have good jobs, but also that family caregivers receive the support they offer. The recommendations also span two pillars in particular. One is improving jobs under the premise that if we improve jobs for direct care workers through enhanced training, clear career pathways, and improved compensation and job quality, we ultimately provide better care, and we also provide better support and respite for family caregivers. The second pillar is really rooted in the policy recommendations that are offered in the Together in Care brief that Jonathan referenced just a few minutes ago, which is that if we think of family caregivers and direct care workers as distinct entities that together play an interconnected role in supporting both the care recipient, but also the family caregiver, we should be thinking about the ways in which how do we strengthen the dyad that specifically supports care partners, right? How do we support workers and family caregivers as a whole? Next slide, please. Within the first pillar, there are a few recommendations that I want to highlight. First is there is a substantive role for federal agencies to come together to fund projects that improve training, that fund job quality, and that improve employment outcomes for direct care workers. They can span a range of areas. They can focus, for example, on both entry-level and specialized training in areas such as dementia, in areas such as cardiovascular disease as two examples. They can create advanced roles that allow direct care workers to stay within direct care, but also play a bigger role in that care delivery, as well as providing career pathways for them to move into other fields or other industries if that's their choice. We can fund projects that support care team integration and that support key populations. Two examples here are immigrants as a critical segment of this workforce, but also the broader US workforce. Another population are rural workers. How do we think about the needs of rural parts of this country? A second area is to think about how can we leverage the public workforce system. So a comment was made earlier in this meeting today about thinking of other sectors or other parts of this country that can play a role in both supporting family caregivers and direct care workers. And I will say here that historically, a big segment of the workforce, including in government, of the sectors that have looked at direct care workers have been departments of health, divisions of disability, and divisions of aging. However, there has been less attention from departments of education, departments of labor, and departments of commerce to think about the recruitment, the training, and the support needs that all workers, especially direct care workers, need. And this is a key role, I think, in terms of recommendations. How can the US Department of Labor and how can other agencies better support direct care workers? Next slide, please. We also need a national standard for direct care competencies, and this is something that's been advocated by numerous national organizations, including PHI and a few others, which is this idea that we need a national standard that can standardize the type of training that we too often see varies across states, across occupations, and across settings. If we were to have a national standard of direct care competencies, then we could ensure that a worker and an employer has the same framework from which to draw when they create training curricula, when they create training programs, and it creates portability across settings, across states, and across occupations. We also need minimum federal training standards for personal care aides, similar to what we see for home health aides and for nursing assistants. Next slide, please. A few other recommendations related to improving jobs. We could benefit from a national compensation strategy for direct care workers that would reconcile the kinds of complexities that we see, from Medicaid rate setting to ensuring competitive wages, not just living wages, specifically in the context of long-term care employers competing with retail or fast food for the same labor pool. We can think about stabilizing schedules and addressing benefit cliffs and plateaus for low-wage workers, which is something that workers across industries face, but is also a challenge within the direct care workforce. And of course, we could see better funding of financial literacy programs so that direct care workers and other low-wage workers could understand their job benefits, they could navigate financial challenges, and they could plan for their own financial futures. Next slide, please. In regards to the second pillar, which is about care partnership support, here federal leaders could pilot projects that improve communication and collaboration among direct care workers, family caregivers, and consumers. What are the best ways for us to design these projects, and how can federal leaders better fund both the implementation and the evaluation so we know exactly what types of projects we can move forward? Medicare's home health benefit can be really critical for funding the kinds of supports that exist between family caregivers and direct care workers, and yet too many people are unaware that Medicare can play this funding role. Here, CMS in particular could launch an education program that makes people aware about Medicare's home health benefit. It could also help caregivers understand eligibility, the kinds of services, and then, of course, enforce caregiver preparedness. We also know that federal and state leaders could help ensure that direct care workers receive the training and reimbursement they need to fund observation skills, right? Direct care workers are often the eyes and ears in the home of so many people and often in other settings. And how can we make sure that those observation skills are properly reimbursed through those methods? Next slide, please. Federal leaders could assist states in outreach efforts that increase awareness of self-directions. Not as many people who are eligible self-direction are often aware of those programs, especially in underserved communities, and federal leaders could play a bigger role in that. The U.S. Department of Labor in particular could commission a feasibility study that would establish matching service registries. These are registries that are essentially online platforms where both workers and consumers can find each other based on their preferences, their needs, and their availability. And yet we don't know exactly what it would take to make sure that a matching service registry exists properly in every single state, and the study would get us there. One of the pieces tied to a matching service registry is making sure that there are sample employment agreements that would aid the independent matching between consumers and providers. And this is another role that federal leaders could play. Next slide, please. The final recommendations are that we really should make sure that we're evaluating and supporting all matching service registries, and that we're incentivizing their state level development in ways that they are as strong and as robust and as effective as possible in every single state. Concurrently, we need more federal funding to back a national survey on services for people under 65 with disabilities, so we better understand what caregiving and support and service dynamics looks like within that population. And we need a better understanding of the private pay home care market experience. So what are the ways in which people who often seek care outside of the formal system, by hiring and retaining their own workers off the books, so to speak, what are the ways in which that system can be better strengthened? And what are the best ways in which we can support both workers, caregivers, and consumers within that sector? Next slide, please. This is simply a listing of the supports of the sources that I drew from for these recommendations and presentations. Thank you again. I look forward to my fellow panelists and my discussant, and thank you for the conversation and opening this up.
Robert, thank you so much for those comments. A lot of good recommendations for our federal agencies, and we really appreciate that. I believe that Rena Aurora is going to be our next speaker. Rena, is that correct? Yes. So Rena is the Director of Care Policy, the National Domestic Workers Alliance. Welcome.
Hi, yeah, for some reason my video, I'm not unable to show my video. Oh, here we go. Perfect. Thank you all for inviting me to be able to present on this. I'll go a little bit into who we are at the National Domestic Workers Alliance, and our role in supporting care workers. You can go to the next slide. And as mentioned before, I'm the Director of Care Policy, and I'm an attorney by training, and I spent many, many years representing individual workers for cases of wage theft in the domestic work and other low-wage industries as well. The National Domestic Workers Alliance is the leading voice for about 2.2 million domestic workers, which includes direct care workers, nannies, and house cleaners in private homes. We were founded in 2007, so we're still a fairly young organization, and it was really focused on strengthening industry standards, making sure that domestic workers could achieve economic security, protection, respect, and dignity in the workplace. Currently, we engage with around 400,000 domestic workers on a regular basis. We have a multitude of state and local chapters, along with 70 affiliate organizations whom we grant and support to organize domestic workers and direct care workers, and are represented in 50 cities and 19 states. Next slide. Part of the origin story of NDWA is really understanding the conditions that left domestic workers out of labor law protections, and our history as, household work being devalued and having its origins in slavery. We have a program within NDWA that's called We Dream in Black that centers the voices and experiences of Black, Afro-Latino, and Afro-descendant domestic workers. And then a part of the history that people often don't know is that, during FDR's Work Progress Administration, there was this set the stage for placing unemployed women to do the kind of care work, and the idea that there would be public funding to support this type of care work, and that 38,000 domestic workers were employed during that time between 1935 and 1942 to meet the new social demand. And then this sort of establishes how the welfare state, drew upon largely like a lot of the Black women workforce to start paying them through public systems to provide this care within private homes. You can go to the next slide. So at NDWA, we recognize that the majority of care done in the US is unpaid. But when we look at home care, and just because of our origin story within the, as Robert and a previous speaker spoke about, direct care in terms of the direct care workforce spans, residential places and nursing homes. For NDWA, we really focus on the home because the home has been a place where they've been under regulation and under recognition of the paid labor force. And so while we recognize that the majority of care is unpaid, the paid home care is largely funded through Medicaid's home and community-based services. Our current strategy is transforming home care jobs through public investment, systems change, and increased data and transparency. So we are looking at workers who are impacted in this sort of public market, however, are not public employees with those benefits, often are agency employed workers and workers in Medicaid funded, self-directed, consumer-directed programs. In terms of its overlap with family caregivers, NDWA supports increased self-direction, as well as what Robert referred to as worker registries that allow individuals to choose their workers, including their relatives. This system allows actually higher wages than what is often paid by agencies, and also allows families to recoup the lost income while caring for a relative. Go to the next slide. So we talk a lot in terms of our advocacy about the care crisis. And, you know, these are familiar points, I believe, to most of you. But just looking at that, we have a growing number of aging adults and persons with disabilities in need of long-term care, right? We have a rapidly aging population. As you can see from the infographic, nearly 50% of Americans 75 and older have a disability, and 1 in 4 Americans between just 65 and 74 have a disability. So, you know, as we often say, you know, in the disability rights community, is that everyone is going to become disabled. And so this is truly an issue that impacts everyone. Long-term care is considered like largely unaffordable, right? And Medicaid is the largest payer of long-term services of supports. So when we talk about long-term care, we're talking about something that isn't just the sort of transitional care that you get if you are being discharged from the hospital and you need some care within your home and there's some oversight by nurses and in terms of medical, and that is covered by Medicare in some pieces. But if we're talking about long-term care, which just is the assistance with activities of daily living for a long period of time so that you're able to stay in your home, that is not covered by Medicare or private insurance, very few, and private pay is extraordinarily expensive. So that, you know, part of the care crisis is that most people would rather receive care within their homes and communities than in nursing homes. However, there is a high turnover and shortage of direct care workers to provide that care because they do not earn wages that they need to survive. And, you know, as Robert said, you can get paid a lot more to work within fast food and retail right now than you do as a labor of love to provide home care. Next slide. So within the universe of long-term services and supports, just wanted to name again, Medicaid LTSS covers both institutional and home care, but home care is optional at the state level. So a lot of what I do in my current role is state level advocacy in terms of the programming and funding for Medicaid HCBS. And a thing that we like to emphasize is that HCBS is not just like home health care or hospital at home. It is really about allowing people to choose where to live and to remain active and involved in their communities, which is one of the reasons we work very closely with the disability rights community, who also, you know, that this is a disability justice issue, also having the ability to receive long-term care within your homes and communities. And so just understanding that Medicaid is the only public payer that actually allows those long-term services supports in the home, we have been working largely on some Medicaid reform as part of our strategy. You can move to the next slide. And then just to reiterate, some of the facts about home care workers, which is that, right now they're serving 9.8 million older adults and people with disabilities. And the size of the workforce has, nearly doubled in the last 10 years from 1.4 to 2.9 million. And per PHI's projections, they're going to be an additional 5.5 million total job openings in the next 10 years. So again, the crisis we have a rapidly aging population and we don't have a stabilized workforce because of the conditions. And so we see, just a massive need for more people to be working in this industry. And also to name what Robert also said, which is that, 30% of home care workers also provide unpaid family caregiving for one or more adults. So we find that our workers are often consumers as well. And that is really about just sort of how care really impacts everyone in all types of ways and how important it is for there to be reinforced support on all levels of care, which I will get to in a minute. And so even though we've seen some increases, and largely with some additional funding that came because of COVID in the hourly wages of care workers, we still see an issue with part-time hours and part-year employment, and that this is not a ability for people to earn a lot. And so the median annual income of a home care worker is only $21,889. So as it's been stated many times before, we are paying these workers poverty wages, and it is a lot to ask for such a critical piece of work that's so important to society to pay poverty level wages to the people providing this essential support is really, really heartbreaking. And we can go to the next slide. So given that, you know, and CMS acknowledges that there are different macroeconomic factors that are, you know, increasing the workforce shortages, and there has been a rebalancing effort towards home and community-based services from institutional care, such as nursing homes, although nursing homes still play an important role. And that, you know, we've seen the inflation is a major issue. And I think I pulled up statistics from a state like Georgia, and I think the wages have only increased 10 cents, you know, for home care workers in the last 10 years. And so our wages are not rising with the level of inflation, and that are all reasons why people have to leave the workforce. So again, there's a lot of, states have a lot of autonomy in terms of how they set up their systems to deal with these workforce shortages. But you will see that the most important way that states are trying to deal with the shortage, or the most effective, is to increase provider payment rates, and also funding, which is funding that goes towards direct care worker compensation and benefits. And that is by far the biggest issue for our workforce. Over and over again, it is the low wages. And so that there are a myriad of other issues and things, and there are other ways to improve recruitment and retention. But right now, the most important piece is raising the payment rates that Medicaid pays for fee-for-service agencies and other forms of long-term care in order to raise the wages of the workers. You can go to the next slide. So for us, we were very excited, and I think we recognize this, that there has been the workforce has become an issue, but there's the CMS really made a pronouncement that was really critical for us being able to move this work within the ensuring access to Medicaid rule, by stating very bluntly that the quality of and access to service is dependent on the working standards for direct care workers, right? And so making that link between access and quality of care, and if you're thinking about continuous care, you need a worker who's going to be able to stay in the field and not be driven out, right? And so quality of care is going to get improved by making sure that we have a stable workforce who is being paid, livable wages. And part of the access rule, which is, got a long runway, but is important in terms of recognizing that with home and community-based services, the majority of public funding that goes into it really should be paid for the workers providing the assisted the activities of daily living, meaning that, agencies have been pocketing, been sort of given free rein to just pay whatever the minimum wage is within the state or locality. But now we're asking for more transparency in the public funding, that, there has to be a cap on administrative overhead or profits that go to agencies, because we need to be able to ensure that the public money is going into the system is actually reaching the people who are the most critical ones delivering the services. But we rely on this nexus of understanding that access to care and quality care is reliant on having a stable workforce, and a stable workforce means you have to have good wages and good working conditions. Next slide. So, you know, when this proposed rule was first given to public comment, we were able to mobilize many workers in order to talk about the conditions that they've worked in, and CMS recognized the voices of a lot of these people in terms of the pressures that they face and how low wages has driven them out of the workforce. And so part of NDWA's role is to make sure that direct care workers understand what's going on in these Medicaid systems and are able to amplify their voices and have influence over the decisions and policies that affect them. And so just wanted to highlight that, you know, that was a big part of NDWA's role, is bringing direct care workers to the table when it comes to these policy making decisions. Can go to the next slide. So one of the other parts of the access rule is that there's going to be an establishment of an interested parties advisory group at every state that the state Medicaid offices will have to build out within the next 2 years. And this institution will require the representation from the direct care workforce themselves, as well as other organizations. And so we really hope to utilize these mechanisms to bring the issues and to allow direct care workers to have a space to talk about what it is that they need in order to stay in this industry and in order to provide meaningful service. Go to the next slide. So when we think of rate setting, you know, our workers really want the states to set payment rates that give workers a competitive wage, that recognize the taxing nature of the work that's being done and the contributions that care has to society as a whole. Because at this current rate, especially pre-COVID, you know, we were dealing with reimbursement rates that were as low as 12, 13, 14. And our workers were still only making $9 to $10. And so we have seen states with additional COVID funding and putting their budgets, increasing those rates to 25. But we haven't seen all of that actually translated into higher wages yet. And we know that there's going to be increased pressures with the lack of COVID relief money for states to make sure that that funding is there. And so our fight is to make sure that states are able to dedicate that funding within their budgets. Next slide. So I'm going to just roll really quickly about some of our initiatives in different states. In North Carolina, we have 2 different programs to support our direct care workers. One is a We Care project, which also includes a fellowship for home care workers to understand the system and learn how to be at the forefront of policy making. And also working on some of the training and credentialing with groups like PHI, and to provide peer-to-peer training to help with that support. Our chapter in North Carolina was also able to get some of the American Rescue Plan Act funding directly for partnerships with from Durham City, where we've been working on credentialing and workforce development, as well as a legal clinic to support our workers, you know, get the skills and get the trainings and just access resources to become advocates for themselves. Next slide. In Maryland, we started an organizing program in Prince George's County, and we've been partnering with groups with Public Justice Center, as well as SEIU's 1199. We were able to pass 2 really critical bills. One that prohibits misclassification by Medicaid agencies as a condition of receiving their funds, as well as a data collection bill that would get critical information that would allow people to make better policy decisions about what payment rates would be needed, and other policies that would support the direct care workers. And so it's, and right now we're working on legislation for the Interested Parties Advisory Group with the support of the Maryland Department of Health and Department of Labor. And so just to state, you know, we believe in broad-based coalitions. There's a lot of work that has to be done across different institutions to prove that things, and we have a very powerful Caring Across Maryland coalition that represents multiple stakeholders supporting these initiatives. Next slide.
Rena, we're gonna have to jump in and conclude here.
Okay.
Do you have any concluding remarks? Because we do need to move on to Kevin Coughlin, just given our own time constraints.
Sure. I just wanted to highlight, if you just want to go to the very last slide. You know, I think as Robert had said, you know, we really believe that to reduce the burden of unpaid family giving, we have to make sure there's an adequate direct care workforce, and that the self-directed models also enable family caregivers to earn an income, and that we are trying to work in coalition with, you know, issues across the care spectrum and to be reinforced so that we can have the infrastructure that meets the needs of the care economy. Yeah, and I can, the presentation should be available if people want to look a little bit more at some of the other state examples. I just wanted to state that in New Mexico, our family caregivers are very much in support of our initiatives, and that is a really important part of having a broad-based coalition, that we support one another through our different policy solutions. Thank you.
Thank you, Rena. And then Carol, if you could just introduce Kevin real quick. Thank you very much.
Yes, absolutely. Rena, thank you so much for that context and background. Next, we're going to go to Kevin Coughlin, who is the Policy Initiatives Advisor for the executive in the Wisconsin Department of Human Services, to give us some more concrete examples. Thank you, Kevin.
Thank you very much, Carol. And just really honored to be here with Robert, Rena, Kezia during National Family Caregiver Month. Thank you so much for having me. Today, I'll be sharing Wisconsin's multifaceted approach to address the caregiver workforce crisis. And I'm going to be talking about WisCaregiver Careers, which is a professional workforce advancement partnership. And this unique partnership is with the Department of Health Services and the University of Wisconsin-Green Bay. Next, please. So we're using Money Follows the Person supplement capacity building funds for this project, as well as American Rescue Plan Act Home and Community Services funding to help support this initiative. And I want to indicate that almost 50% of our funding is going through to pay incentives for directly to our caregivers. Much of the rest of it is really building the infrastructure for this program to move forward. Next, please. So in Wisconsin, we had training requirements in our home and community-based services that were kind of like the Wild West. You know, the training really was dependent on participant groups, the settings, funding sources, etc. So we developed a free training that would be available to both our direct care workers as well as family caregivers. So this certified direct care professional, prior to creating it, we did our homework, and everything was built around national competency standards. And when we built this, we also got a lot of information from key collaborators throughout the state, and our competencies really exceed national and state standards. And I'm really proud of the fact that our direct care workers in our listening sessions voted for the name, and the certified direct care professional was really important to them and important to us as well, that they are recognized as professionals in this extremely important role that they provide. And part of our training, which is a certification, it does include a proctored exam and a public registry that I'll talk about in a little bit. The certification is not a certificate, so having a certification really opens a lot of doors for us. And it's similar to when we think about a certified nursing assistant, a CNA. This is for those people working in our HCBS settings, and it is a 3-year certification. Next, please. The other component of our project is what we're calling our micro-credentialing and badging, virtual badges. And what's unique about this is that these were leveraging current training programs that are offering training that would be appropriate for a certified direct care professional who wants to upskill in certain areas to become more efficient in the type of work that they want to do. And then it also is going to tell their employer or a family member who might be looking for a caregiver the things that they can bring to that skill level. Next, please. So we just launched our micro-credential and badging program in June of this year. We had a webinar and we invited a number of potential training partners. And here are a few of the themes that we're looking forward to having as part of that accompanying training to go along with our certified direct care professional. And then if we identify like gaps that are not available, then we're working with our training partner, University of Wisconsin, Green Bay, to create some of those additional micro-credentials for us. And I think what this does is really gives us flexibility throughout the populations, the settings, and the funding sources. So an individual might if they're a certified direct care professional, take some additional micro-credentials to meet all the training requirements for a certain setting that we have. And then the other thing that's been really nice to see is our certified direct care professionals receive these virtual badges, and they can put it on their social media, their resumes, their email signatures. And we're starting to see those pop up as they're reaching out to us in the email, and we see their virtual badges attached. And I think really bringing that recognition to our certified direct care professionals has been an important step. Next, please. Next, we have a registry. So these registries will include all of our certified direct care professionals. And this is an example of an individual who also has other trainings that they've taken, and this will be where their micro-credentials will be reflected as well. So an employer who is looking to hire someone that can look up the registry and make sure that this person has the training that they're looking for and the skills that they need. Next, please. Another component, again, of this multifaceted approach is our job matching platform called WISC Caregiver Connections. We've branded it with our logo and branding, and this is available to both our employers and people who are self-directing their care, as well as our certified direct care professionals as they're coming out of this training. So there's auto matching, they can set up profiles. Again, this is free. We heard a lot from employers on how much recruitment costs are hurting them, especially with the high turnover rates that we have. So again, we're trying to decrease the barriers that both our employers and our people looking for jobs have to incur. Next, please. So we're using our funding, as I indicated earlier. This is free training. We're hoping to recruit 10,000 certified direct care professionals, and we're incentivizing this program with sign-on or stay-on bonuses of $250, and then also a 6-month retention bonus if they stay with that employer. And this is it's been an important kind of part of our secret sauce, free training and receiving incentives that we're using in our marketing. Approximately half of our registrants that apply to become a certified direct care professionals are brand new to caregiving. So we really like to see that because we need more and more people to come into this field. And then the other half are current people out there that are trying to upskill, and it is a big initiative of ours, is how do we get the whole caregiver workforce increase their competencies and raise the whole group. We also have a couple of other referral programs with Refer a Friend. So we know certified direct care professionals are a cohort. They have all kinds of friends that they have that are also in this field. So they get a referral if if their friends become a certified direct care professional, and a teacher referral. And I'm going to talk a little bit about that later. So next, please. So we have a comprehensive marketing plan to recruit our new and existing caregivers to sign up for this training and job matching platform. We launched our certification in July of 2023. And we're just, a little over a year old. And we're using multi ways of connecting to people with social media, print ads, TV, radio. And as of yesterday, we have 9,980 individuals who have registered to become a certified direct care professional. The other thing that I heard a lot today is about data and information, and we're collecting a lot of demographic information regarding these individuals. Next, please. Next, I want to talk about ladders and lattices, and also with the relationship that we've developed with our state partners, which I've been very proud of. And one of our partnerships has been with Lynn Gall, one of your advisory participants, and she's with our public health department. And it's been really, Lynn's been really instrumental in advocating for family caregivers and trying to eliminate the silos between family caregivers and direct caregivers. And so it's been a real important aspect of this program is, our family caregivers should receive as good a training as our direct care workforce as well. So, so we have that great partnership. And then as I move forward, you're going to see a lot of our state partners who are funded by federal agencies within this meeting today. So our regulatory agency, our Division of Quality Assurance, CMS oversees that program. They've been instrumental in sort of knocking down barriers where we can, if there's an equivalent training in our certification, that people don't have to take that. So it's really trying to eliminate some of the barriers that a person has when they maybe want to move to another setting or want to advance their career. And then the other exciting project is we're working with a nonprofit organization to create a ladder from our certified direct care professional to CNA. And we heard from many of our individuals that they are looking for career advancement with their program. Next, please. So some of the other collaboration we've been doing is with our Department of Public Instruction and our Department of Workforce Development. And these partnerships we've created we're trying to engage high school students who early on consider a healthcare career. And our Certified Direct Care Professional program now is recognized by HOSA. If you're not aware of HOSA, almost all states have a chapter, and it's really to help support individuals in high school who are looking for a healthcare career. And we're also on the Regional Career Pathway, which is a program to match employers and students along with training programs. And we have some great stories about how high schools have incorporated our Certified Direct Care Professional into a semester-long training program where they maybe come out as a Certified Direct Care Professional along with like first aid and choking. There's also been summer self-study programs where they get credit for that and also extra credit. I think it's so important to encourage young people to think about a healthcare career and, how do we support them through that process? Next, please. So another important concept has been language access. And this is, it's very important to help individuals who maybe are limited in their English proficiency to have access and support in that program. So in March of 2024, we launched our Spanish version, and it's everything. We have a website, our marketing, our communications, the curriculum, and the tests are all in Spanish. And this month, we are looking at launching Hmong, which is our third most spoken language in people's homes in Wisconsin. And then we're early on in some exciting work with state refugee and resettlement programs to tap into, how can we support refugees who are interested in this healthcare career as opposed to them maybe going to manufacturing where some of the language issues are not as big of an issue. Next, please. So as we designed our program, we really front-loaded the development and implementation costs using both MFP and ARPA. And then as we've gone along, we've tried to incorporate this into all of our much of our like standards that are already in state, that with requirements for training, we want them to recognize our certified direct care professional. We have it will be incorporated into our CMS waiver renewal. And in the end of the day, we're going to be rich in data. We're going to have a lot of information that we collect throughout this process. We have a whole pipeline of data showing kind of when people, who they are when they register, how many are making it through training, how many are getting jobs, how many are getting their 6-month retention. And then we also have another academic partner who is doing qualitative and quantitative evaluation of our program that will also help tell us that information. And we have tons of stories already that we're hearing from direct care workers about how this has been impacted on their life. And then we are building this into our biennial budget request. So we don't want this just to be a one and done. I think it's important for us to be able to continue to support people, but we'll be able to do this very economically efficient and with high quality because of how we've built the structure and our partners that we have involved in this program. Next, please. This was just we had a nice shout out from the White House convening when they were talking about the investment of ARPA and how critical this has been. And then with our technology, we've been able to do virtual meetings with 22 states about our program and how we've done it. And then we also have one particular state that has really adopted the program. They're working directly with Wisconsin, with the University of Wisconsin-Green Bay to kind of replicate what we did in their state as well. So the next slide, I want to spend a little bit of time here because I think the Wisconsin model is scalable, it's replicable, and could be really a national model. And, I know this advisory council is a council of action, and if there's an interest, this model could become kind of the basis of what a national model could look like. And it would be high quality and extremely cost effective. So, the university could, we could take all the Wisconsinisms out of our curriculum and have it a national program. And again, it's based on national standards anyways. So that could be sort of that foundational training that could be, anybody in the United States could take. The registration would be easy. They could add a drop down, pick your state, and that registry would be available for those states and the people taking that training. The micro-credential, I think, is kind of that game changer that allows the flexibility and adoption of other states where they could take the certified direct care professional plus their state supplement training to meet the requirements that they would need for their populations that they serve. And again, the job matching platform could be a drop down, pick your state, find out which employers are out there. And then I think the other part is the marketing, having this as a national website where everything is geared to one site, and there could be all of the marketing assets could already be created for each of the states so that they wouldn't have to do that, and then they could take that information and create their own marketing plan around some of that toolkit that would be available. And then, of course, a national advisory group that could be represented with all the federal agencies involved, state agencies, and key collaborators. Next, please. So the next just couple, and I think I'm getting close to time. We've had a lot of nice coverage about this model from some of the national organizations. Next, please. Here is a listing of all the resources. If you want to dig into this a little bit more, it's available for you. And next, please. And finally, just if people are interested in hearing more about it, be happy to do a more in-depth briefing of sort of what we're doing and how we're doing it. And, I would just hope you would consider kind of looking at this model to be included in that goal 6 of the direct care workforce. Thank you very much.
Thank you, Kevin. What a wonderful, fascinating presentation. Next, I'm really pleased to go to one of our council members for a response. Keisha Scales, Vice President of Research and Evaluation for PHI, will provide some background and comments for us. Keisha?
Thank you so much, Carol, and thank you, everyone. It is a privilege to serve as discussant on this critically important topic with such an incredible group of experts that we've heard from today. And I do want to note, it's quite apposite that as well as it being National Family Caregivers Month, it is also National Home Care Aid Week this week. So it makes, it's really appropriate that we're having this conversation today. This has been such a content-rich afternoon. I feel both excited and a little bit intimidated to think about how to draw out sort of concluding remarks from everything that has been shared already. But what I really do want to do is emphasize and extend some of what we've heard already. And so I think you'll probably hear me say the word emphasize and underscore quite a lot in my discussant remarks. But I especially want to help draw out how today's conversation can inform our council's deliberations around updating the national strategy to include a new goal that is entirely focused on supporting and strengthening the direct care workforce. So first of all, I just do want to underscore the importance and value of this workforce. As we heard really from the start of today's meeting, the care that direct care workers provide can help family caregivers keep their jobs, if that's their choice, maintain their financial stability, safeguard their own health and well-being, and access respite as needed. But conversely, when direct care workers are not available or not accessible or not affordable, family caregivers and the individuals they care for and our communities and our economy all suffer the consequences. So to put a fine point on it, and I think this is already built into the strategy to some extent, but we cannot effectively and sufficiently support family caregivers if we don't also support direct care workers, strengthen and stabilize this workforce overall, and support the interconnection and overlap between family caregivers and direct care workers. And in all of those efforts, as we've heard from various speakers today, we do need to keep building the evidence base on the return on investment for these efforts to really be able to show that this matters from whatever perspective you're approaching it. This is a worthwhile investment because it pays dividends on every level. And I'll try to come back to that in my remarks a few different times. But to look a little bit in turn at each of this panel's speakers in particular, Robert Espinosa did a great job of summarizing a range of actions that can and should be taken at the federal level to improve jobs for direct care workers and support family caregivers and direct care workers together. And some of those actions were built into the 2022 strategy, and some progress, I want to celebrate that some progress has been made. And Maura Cousin at the beginning, Principal Deputy Administrator of ACL, gave some of the examples of the type of progress that has been made on the strategy. But specific to the workforce, I could add that ASPE has led research on state policies for improving compensation for direct care workers. The National Institute on Aging has funded research on this workforce in dementia care specifically. The Employment and Training Administration of the Department of Labor has earmarked grant funding to improve job quality in key sectors, including for jobs in the care economy. And of course, ACL has funded the National Direct Care Workforce Strategy Center, which is a 5-year initiative dedicated to improving direct care workforce recruitment, training, and retention across the country. So progress has been made, and much more progress is needed. A handful of actions, however powerful, is not enough. But if we consider including a new goal in the strategy that's entirely focused on the workforce, we could build out a more comprehensive set of actions, that's needed at every level, and including, but not limited to, actions that are needed at the federal level for our federal partners to own and implement. And what I want to say about that on the federal level, as Robert's presentation showed, there has been a lot of work done already to identify and specify and promulgate the types of actions that are needed by experts and advocates in the field, including PHI and NDWA and the National Alliance for Caregiving and others. So we're not starting from scratch by any means. There are a lot of existing strategies and solutions that could be pulled together into this new goal. And some of the federal level actions that will be needed going forward will involve holding the line on progress that has already been made. And Tori Cross from Caring Across Generations made this point really compellingly in her remarks earlier. And I want to say it again, because I want to underscore that there is, in my opinion, no time to waste in championing and codifying the role of federal leaders, our federal partners, in addressing the workforce crisis as a key part of supporting family caregivers and the care economy overall. So we have a lot of progress to make, but we also have progress that could be undone. And we need to support federal partners with a clear mandate about how to move forward and not backwards. And I think the Medicaid access rule that Rena described is one really critical example of that, the imperative to hold the line on progress that has been made. And so on that note, I would love to shift and say a little bit about Rena's presentation, which offered a really powerful overview of the historical context and the current interconnected federal and state context in which direct care jobs are constructed and in which this workforce operates and provides services. And from Rena's remarks, and also echoing remarks from Natalie Keene in her presentation earlier, I want to echo the point that we cannot resolve the workforce crisis at no cost. More investment, absolutely more investment through Medicaid and other public payment structures and sources is essential to raising direct care wages, strengthening employment benefits, and generally making these jobs more attractive, competitive, and sustainable. And there is room, and in fact, there is an imperative, I would say, to be creative and ambitious in pursuing all of the strategies, including strategies that leverage and maximize existing payment streams and sources, even as we are advocating for better investment overall. And I think that's what this council can be keeping in mind as we consider potential updates to the national strategy. What might we help promote regarding the direct care workforce that is possible within the parameters of the strategy, acknowledging that parallel efforts through different agencies and different channels will also be needed. And one point that I wanted to draw out that was sort of implicit in Rena's presentation, I hope it was because I sort of saw it there, was also the important role of employers in all of this, in all of our thinking about strengthening and supporting the direct care workforce. So it's really so important to identify the federal leadership that's needed and all of the state level policy actions that are needed, but also to directly engage employers. And many employers are actually out there doing what they can to improve job quality and better support this workforce, even with the most constrained resources. So I would say that as we're thinking about a potential direct care workforce goal, we keep employers in mind and think really specifically about what actions they can and should lead in all of this. And then turning to Kevin's presentation and the state level perspective, I just have to say it is always a joy to hear Kevin present on Wisconsin's efforts to strengthen and support the direct care workforce. And what I really want to emphasize is the multifaceted approach that Wisconsin is taking to address a multifaceted set of workforce challenges. So I'm going to say in one breath everything that Kevin said. I'm going to try. I'll take a couple of breaths because I don't want to speak too quickly. But you heard from Kevin about the Certified Direct Care Professional entry-level course and the micro-credentials that workers can layer on top, and the online statewide registry to track and sort of evidence those credentials, and the workforce platform that connects trained and certified workers with employers and employment opportunities, and the financial incentives and supports available, and the proactive marketing and outreach to promote uptake, and career ladders and lattices built in, and cross-agency partnerships to generate new recruitment pathways, and language access, and evaluation, really importantly, evaluation to assess implementation and impact and to inform sustainability plans. And I wanted to say that all again because it really illustrates the type of comprehensive approach that is needed and that could be built into a new Goal 6 on the workforce in the national strategy. And I do want to add, and thank you, Kevin, for your comment in the chat, that Wisconsin's approach really does resonate very closely with PHI's vision of a multifaceted approach to developing out a universal core competency-based training and credentialing system that prepares and rewards direct care workers as they care for an increasingly complex population of older adults and people with disabilities alongside family caregivers. And that also, part of that echoes the comments that Jonathan Cotter, the council co-chair, offered earlier about elevating direct care as a viable career option, making sure that people are really available, that this is an opportunity, and making it possible for people to choose, to be able to afford to choose to do this work that many are called to do. And part of that is just elevating, it's not just, but is elevating the professional recognition of this incredibly important set of roles and creating the infrastructure to support and compensate accordingly. And there are other states around the country that are following Wisconsin's example and exploring this vision of a more coordinated universal training and credentialing system to support a strong, stable, flexible direct care workforce. And in noting that, I just want to return to the ACL-funded Direct Care Workforce Strategy Center because it's such a valuable resource in this work. And alongside offering resources and technical assistance to individual states as they explore these opportunities, the center is and can connect states to each other and facilitate interstate learning. And that is so important for moving beyond incremental changes toward more collective national progress. So that's a piece of the Strategy Center role that I think should continue to be prioritized in the years ahead. So I'll wrap up my discussion comments now. In wrapping up, I just do want to reiterate that a lot of work has already been done to identify and in some cases implement the actions that are needed at the federal, state, and local levels to build a stronger direct care workforce. So as we, the council, consider adding a new Goal 6 to the national strategy, we can leverage and help move forward that good thinking and good work that has already been done. Thank you.
Thank you, Keisha. Thank you very much for all of those responses. And to all our panelists, I'm assuming that there are a lot of questions out there after such wonderful presentations. We've got a few minutes, I believe. So if anybody has a question, if you'd like to raise your hand, and we'll go ahead and get started. Deborah.
Thank you, and I'm glad that your sound got fixed, Carol. My question is, as I was listening, and thank you very much. These were all extremely informative and hopeful presentations. My question is around looking at the difference between rural and urban direct workforce training, availability. I lived in an extremely rural place for 25 years. And I know that as a council, we need to, as we're putting forth recommendations, consider that. But I wondered if any of the panelists have thoughts on, you know, how we as a council can formulate our recommendations so that we're being inclusive of rural and not creating unintended consequences, making it more difficult for family caregivers to access assistance in those areas.
Kevin has his hand up. Do you want to respond, Kevin?
Sure. Yeah. So, Deborah, thanks for that question. And, you know, we thought a lot during our research on, you know, should this be in person, online, combination? You know, I think we learned a lot in COVID that we can do pretty good training online. And that's the direction that we ended up going because we wanted it to be accessible to all individuals. You know, having Wi-Fi access is, you know, still kind of a challenge in some areas. But we're looking at all of our registrants, and we know kind of where they're all from. We're doing geo mapping, and we're in all 72 counties. We're in very rural. We had a colleague of mine lives in northern Wisconsin. Anybody knows if they know about that? It's very rural. And she said, "Oh, it was so exciting. I saw your TV commercial, and then it was in our weekly newspaper. So they get it once a week. And we had an ad there. So, you know, I think we're really trying to reach everyone and support all of that. So it's been very effective so far."
Great. Thank you, Kevin. Any other comments?
Yeah, if I can speak a little bit to it, I really appreciate that question. For me, it brings up like, you know, a conversation about what is different about rural areas that might require unique interventions, and how should we be thinking about this in the context of both workforce need and family caregiver needs. And a few thoughts come to mind. I mean, Kevin mentioned the issue around inaccessible internet, right? This is something that rural parts of this country really struggle with. And I think the more we think about that as a unique challenge, I think in the context of workforce, what that could mean is that to the extent that we think about technological supports or innovations as either something that will address this system or will help bring kind of more workforce capacity, there will be limitations, right? I think having limited internet access in certain areas makes it more difficult to be able to, for workers, for example, to use technological devices and Wi-Fi in ways of that I think we're seeing more and more, right? A few other challenges that I think show up in the context of rural America and the workforce. One is the reality that beyond the workforce, there are limited health and social services in rural areas. And so this means that there are also fewer hospitals, there are fewer primary physicians. Oftentimes people have to travel quite a bit to go from one area to the next. And I think that will shape how direct care is delivered in rural parts versus more urban areas. I think there are also fewer younger people and fewer public transportation options. And so to the extent that workers often have to drive, for example, you know, quite a bit long distance in order to get from one client to the next or from their own home to a specific setting. I think that comes into consideration as we think about rural areas as well. And then just the vastness of so many rural parts of this country that it might take a worker an hour, 2 hours to get from one city or town to the next. And yet that will raise attention to the ways in which employers and ultimately public funders are supporting people's transportation methods, their cars, their gasoline, et cetera, which isn't always in consideration. So I do think looking at the uniqueness of those barriers will be relevant.
Thank you, Robert. Keisha?
Yes, thank you. If I could just add a couple more thoughts. I agree with all of the responses so far. And I think that it would behoove us to look across the strategy to see how that lens or filter has been applied already in general, because a lot of sort of resource access challenges in rural versus urban areas can pertain across a lot of the areas. And then I would definitely sort of agree with you, Deborah, about bringing that filter to our own thinking. And maybe expanding it a little bit to think about underserved areas. So thinking about rural versus urban divides, but then thinking about different communities that may have other access or equity challenges that are not necessarily on that particular axis. And then one other point I think I would make is, I think we'll need to be thinking about what are the strategies that maybe bear adaptation to particular areas, and what are the strategies or interventions that may be unique to rural areas versus other areas. And I would uplift one example that we've talked about throughout this afternoon, which is the self-direction model, and really thinking carefully about how much that may particularly benefit more rural areas, but what may need to look different in those programs to make sure that they are really accessible and effective.
Yeah, thank you very much.
Yeah, just one thing to add. I mean, we are working towards trying to get South Carolina to commission a study on long-term care, because what we've seen is that actually providers have quite high reimbursement rates, but they're only having about 3 hours of authorized service for each client. So they're unable to retain workers in the workforce because it's like 3 hours a day in these in rural areas. And so then you don't have people where that makes sense to have a job like that. And then there's questions over the transportation costs, if it's considered commute time versus working time. So just to say, I think that, what is really important in terms of data and building the case is that some of our assumptions don't always work in every new place. And so we have to be really attentive. And, I work in Georgia and South Carolina and North Carolina, and they all have different issues. And I think South Carolina is a very rural area. And I think it is really important to make sure that interventions really match the landscape of the system that's being worked in.
Yeah, thank you, Rena. I heard several really good comments about underserved, Keisha, as opposed to just the rural-urban divide. I think a lot of times we do forget about it, but we also do forget about we are trying often to serve more caregivers, and so that 3 hours comes into play without thinking about the impact that has actually on the workforce. So those are great points. I don't see any hands raised right now, so I'm going to ask my question. In preparing for the meeting, there was a wonderful issue brief, Together in Care, developed by PHI and the National Alliance for Caregiving, talking about the promoting the team integration between the family caregiver and the direct care worker. I haven't heard much about this particular subject, and I'm curious if anyone would kind of like to talk about the important relationship between those two, especially in the healthcare setting, where that we see that integration as really critical to continuity of care.
Maybe I could jump in first, Carol, and then I welcome my co-panelists as well. So there's a couple of things I would say. One is that I think through experience and through research, we know that the absolute value of that triad of the family caregiver, the person receiving services, the family caregiver supporting that person, and the paid direct care worker when the paid caregiver is in the mix as well. Of course, that oversimplifies. There are many other folks in the mix, but when you really distill it down, that relationship and the quality of that relationship is so incredibly important to everybody's experience in that situation. And so that's the sort of starting point for that thing, thinking about care team integration, is just how do we first and foremost support the development of quality, productive, mutually beneficial relationships between family caregivers and paid caregivers in the provision of this very, very important, often very intimate home-based care. And then always sort of thinking about the person receiving that care as central to that effort. And then moreover, thinking about the fact that this is the caregiving triad that knows the most about that individual's caregiving needs and moment by moment status and well-being, and yet are often both family caregivers and paid direct care workers have often and continue to be marginalized relative to the more clinical care team that's in the mix. And so thinking about that's a real shared challenge between these two sets of caregivers. And so thinking about what would it take in both policy and practice to structure more meaningful engagement between those home-based care providers and the broader interdisciplinary care team. And we have seen some of that, a little bit of that effort happen on both sides in policy developments, but there's a lot more to think through about what does that look like and what does it take to really, again, meaningfully involve family caregivers and paid caregivers in communication, engagement with the interdisciplinary care team in an ongoing and bi-directional way, so that they really are central part of the care planning and assessment and delivery process all the way along.
Thank you, Keisha. Yeah, I think the observation, I believe it, Robert, and I see your hand there, but the observation and reporting that you talked about, Robert, really is, I think, intriguing in terms of making sure that the healthcare side sees the importance of family caregiver and the direct care worker.
Absolutely, and I would 100% agree with what Kezia shared. I would also say, you know, I worked at PHI for about 10 years, and I do feel like most of the stories I heard from friends and family members when they would talk about direct care workers often came from stories where they felt like when they needed care and when their family members needed care, that the direct care worker went above and beyond to what they wanted, right? And so, for example, people would tell these really powerful stories about home care workers and palliative care, and sort of, you know, when their family members were passing away and were in that stage, that it was their really thoughtful direct care worker who was attuned to their emotional needs, but also to their basic support needs that they often remembered the most, right? And I think, to underscore Kezia's point, it's because when that relationship is strong among that triad, the care that is received is transformational, especially when it's in a moment of incredible emotional crisis, right? But it's when it's not strong, I think it can be really destructive, right? It can actually really harm the person's care, and it can really affect how everyone is interacting. So I would double down on the reason why those relationships are so critical is that they offer coordinated support, right? They can ensure that family caregivers and direct care workers are working together to meet the client's needs and preferences. They provide holistic care, so you're making sure that the client's history, their preferences, and their emotional needs are taken into consideration. And there's a lot of problem solving and emotional support and in the moment thinking that is so critical among those three kind of partners in care, right? And I think making sure that that relationship is as strong as possible, so that you're thinking through the person's needs and their aspirations at every critical time, which is constantly evolving. I think that's a critical piece of it as well.
Great, thank you. Any other comments?
just to add, as I indicated in my presentation, we wanted to make sure that training was available, regardless of whether you're a family caregiver or a paid direct care worker. So that we make that available. They might not be eligible for some of the incentives unless they are caring for somebody in our program. Then a family caregiver can also receive those incentives. Thanks.
All right, thank you. Okay, I see that we're running close to time, and would like to go ahead and turn this back over to either Jonathan or Greg. Did you wish to close us out?
Yes, I do. Hey, everyone. This is Greg Link, and I just want to thank the two panels that we had today to talk with us and to begin providing the advisory council with the information that they're going to need as they begin considering what an updated strategy will look like. As you can probably tell, this was very much an information in kind of a meeting, meaning that we had external stakeholders and experts providing information to our advisory council members to help facilitate some of their deliberations and decision making. It's kind of a new approach for us with these meetings, but it's one I think we're going to be seeing a couple more times as we begin to pull apart the existing strategy and in subsequent meetings and begin to delve into a little more deeply some of the other goals and recommendations and where can we take them, where can we build them out, how can we expand on things. And so what is going to happen next is we're going to be taking all of this information that came in today. And I can tell you the comments in the chat have been so helpful and so fruitful, as well as the information provided by our presenters. And we're going to begin organizing that into a basic framework for a new goal 6, perhaps. And then also beginning to look at some of the federal legislative and the congressional and legislative and executive branch ideas that came from our Act on Raise colleagues and begin to formulate that into some kind of a structure. Now, as we head into a transition in administrations, we're going to need to take the lead of the incoming administration to see, when our next meeting will be. I'm hoping that it will be sometime in the winter where we can convene another advisory council meeting like this to begin to delve into a couple of the other goals in the strategy and really begin to help us think about where we move next with it. In the meantime, we are going to be pulling all of this information together into a meeting summary that will be posted on the acl.gov/raise website, along with a link to this recording and the PowerPoint slides. So that's going to take a couple of weeks at least, because we have to go through and clean up the transcript, make sure the closed captioning tracks with what everybody was saying. So it's not going to happen tomorrow, and it likely won't happen next week. We've got holidays coming up. So stay tuned for all of this information to be uploaded onto the website. And then you will likely be hearing more about a future Raise Council meeting in early 2025. Before we close out, I just wanted to turn to the council members to see if they had any last-minute thoughts or comments before we end for the day. Well, I see not a one, and you all are probably tired. I want to thank you all so much for your time and for your attention, and during Family Caregivers Month, for your dedication to this particular issue, and then to the members of the public who have been watching. We thank you so much for your support and your interest in this topic, and you will be hearing from us more in the future. And so, with that, we will call this meeting adjourned. And everyone have a wonderful holiday season and a happy new year. Thank you.